Greetings from California, USA, to all of my esteemed patients, their families, colleagues, dedicated advocates, supporters, and viewers participating in the virtual endometriosis conference hosted by Worldwide EndoMarch and the American and Global Congress of Endometriosis Subspecialists. As I address you today, I am profoundly honored to speak to a community that has shown an unwavering commitment to the cause of endometriosis awareness and advocacy. Over the past decade, the worldwide EndoMarch has evolved in a powerful force transcending borders and bringing us together in a shared mission. Yet, as we have tirelessly advocated for those with endometriosis, a glaring reality has become apparent. The lack of endometriosis specialists around the world to treat patients in need. In response to this urgent need, we founded the American and Global Congress of Endometriosis Subspecialists, ACCESS in short. Our goal is to train the future generation of healthcare providers, ensuring that individuals with endometriosis receive the specialized care they deserve. This year marks the inaugural year of our organization, and we are proud to announce that we have highly esteemed experts from around the world participating in this year's virtual program. Reflecting on these 10 years of worldwide EndoMarch and the launch of the Congress, I am struck by the incredible strides we have made in raising awareness and fostering collaboration among the healthcare professionals, researchers, and advocates with patients involved in every step of the way. We are not just raising awareness, we are actively addressing the shortage of specialists and training providers, and hopefully other educational entities will devote more attention to endometriosis care, research, and training. As we look ahead, the mission remains crystal clear: to continue pushing boundaries, challenging norms, and driving advancements in the understanding and treatment of endometriosis. From my vantage point, I see a future where the silent suffering of individuals with endometriosis is acknowledged, understood, and met with effective solutions. Our collective vision is that one where early detection is the norm, where treatment options are not limited, and where the stigma surrounding endometriosis is dismantled. It is a future where the worldwide EndoMarch and AGES serve not only as platform for awareness, but as the catalyst for tangible change in the lives of those affected. I am inspired by the dedication of each and every one of you, and I am confident that EndoMarch will continue to be a driving force in the global fight against endometriosis. Together, from California to every location around the world, we will persist in our effort to make a difference. Thank you for your commitment, your passion, and your tireless advocacy. Forward we go. Our first speaker is Dr. Robert Waugh, an esteemed healthcare leader, renowned for his expertise in healthcare, IT, advocacy, and strategic development. He is former president of American Medical Association, the largest medical society in the world. Dr. Wa currently chairs the Board of Commons Project, the innovative force behind COVIDcheck.org, a global risk assessment tool aligned with CDC and WHO guidelines. Dr. Wa is very distinguished, a Harvard Medical School alum with dual board certifications. Dr. Wa's contributions extend to Harvard Business School's Advanced Management Program. A former chairman of the American Medical Association and advisory board member of Worldwide EndoMarch since its inception in 2013, Dr. Wa was originally acknowledged as Endo Hero of the Year in 2018 for his exceptional work in supporting patients with endometriosis and their families. We eagerly anticipate his insightful presentation at the virtual endometriosis conference. We thank you very much, Dr. Wa, for his unwavering support all these years. Thank you. Forward we go.
Hello, my name is Dr. Robert Wa. I'm a member of the advisory board, and it's my privilege to help kick off and welcome you to the 2024 Worldwide EndoMarch. I'm a reproductive endocrinologist who has been working to help patients with hormonal disorders, infertility. I do microsurgery, minimally invasive surgery, and in vitro fertilization, along with teaching medical students, residents, and fellows. I also worked in health information technology for over 30 years. I bring you greetings from Colorado. Here it's sunny. This is the view of my back deck. It's a great honor to be part of the Worldwide EndoMarch. I've been asked to talk about the social implications of endometriosis. A number of my physician colleagues will be talking about the medical and clinical issues of endometriosis. But we thought we'd start by setting the stage for this EndoMarch this year, talking about the social issues as well. For most of this audience, you all know the social impact of endometriosis. It's been conservatively estimated that over 200 million women suffer from endometriosis. It's most likely that that number is approaching 1 billion women due to the problem that we have with underdiagnosis of endometriosis. And certainly the wider impact of endometriosis is felt because all of us have patients, wives, mothers, sisters, aunts, family members, colleagues, and friends who suffer from endometriosis. So that impact is much wider than just the women who are suffering from endometriosis. I also wanted to spend a few minutes talking a little bit about the history and progress of the Worldwide EndoMarch. Many of you here that are with us today probably remember back in 2014 when we had a very, very impressive kickoff of the Worldwide Endometriosis March. It was also very impressive on how windy and how cold it was on the mall in Washington, D.C., where we all assembled. It was also impressive on the huge array of really stars that the Najat brothers and family brought together for the kickoff of the 2014 worldwide EndoMarch. There was a great musical performance by Sheryl Crow, along with great leaders in medicine, industry, and really the world that helped kick off this process. And to those of you who have who have been with us since 2014, I think it's a great testament to the Najat's insight and foresight to think about kicking this off and where we are today. In those 10 endomarches that we've had, it's been estimated there's over 300,000 people that have gotten involved in this process across over 70 countries. Also in 2020, the American Medical Association, the largest medical association here in the United States, gave recognition to Cameron Najat by giving him the Distinguished Service Award. It's the highest award the American Medical Association gives, and was partly for his pioneering work in video laparoscopy, minimally invasive surgery, robotic surgery, but it was also in recognition of the work that he and his brothers and his family have done in kicking off the worldwide EndoMarch process and raising the awareness and trying to find solutions and cures and treatments for those 200 plus million women that are suffering from endometriosis worldwide. Also this year, I think it's exciting to see the launch of the American Global Congress of Endometriosis Subspecialists. This is a great effort to really kickstart the next generation of subspecialists that will be treating women suffering from endometriosis. And so it's a huge advance in the field, and it's great to see it start this year in 2024. Again, the impact of this disease across the world is known to all of you in this audience, but for those of you that are tuning in for the first time, it's important to note just how big endometriosis is as a problem in healthcare today. And there are issues of access in healthcare, also in the healthcare for women that are suffering from endometriosis. One of the key pillars of the Worldwide EndoMarch is talking about the ease of empowerment, education, and affecting change. And that's what we all come together today, as we have for the other 10 years of the Worldwide EndoMarch, is to empower patients and their families to seek out proper and effective care for their problems and diseases, and to educate not just the patients and their family, but also the greater medical community to better recognize endometriosis and know that there are proven treatments and therapies for this, and also to educate legislators, policymakers about the importance of endometriosis and how much of an impact it has across the world. And that is to then lead to affecting change. And the place we want to affect change is, again, at all levels of access to care for patients, better diagnosis and treatment of patients with endometriosis, and also better policy that will help fund research and advancement in the field of endometriosis, so our patients are diagnosed earlier and faster and get appropriate and effective therapy to help treat this really devastating disease that's out there. I think it's really important to remember that when people come together with knowledge and passion, we can really accomplish amazing things. I had the privilege of serving over 23 years on active duty service in the United States Navy. And one thing I learned from being in the military was the great power and possibility of what I call unity of effort. When people come together focused and joined with a unity of purpose and effort, truly amazing things can happen. And that's what I love about the worldwide EndoMarch process. It brings together all of us that are passionate, knowledgeable, and really seeking to see improvement in the area of endometriosis. And so this whole process that we have today is to bring together medical experts, patients, again, legislators, policymakers, to find ways that we can advance the help and care of patients with endometriosis. And so please join us in this march. Tell your friends, bring in others, spread the word, but also use your knowledge, your passion, and your drive to advance this process of finding better ways to take care of patients and women that are suffering from endometriosis. So again, it's a privilege to be with you all. I also want to acknowledge and thank Cameron, Far, Sena, and their niece Ozzy, the Najat family, for starting this process, having the forethought and the insight to start this process of raising the awareness of this huge health problem that many millions of women are suffering from across the world. So it's, again, privileged to be with you all. As I finish up, I also want to say that as devastating of a problem that we're facing and the hard work that we're doing here, I want to also say, let's also continue to have the tradition of having fun at the Worldwide EndoMarch. This is one of the little things that I found that, from one of our past EndoMarches. I hope it comes in on the video. But it's just a reminder to have fun of being together in this fight for endometriosis treatments and diagnosis. So again, thank you for your time. I look forward to a great day with all of you and a great year of advancing our fight in the process of finding better treatments and care for women with endometriosis. Thank you very much.
Hello, our next esteemed guest and recipient of the 2024 Endo Hero of the Year award is Miss Safra Katz. As the CEO of the Oracle, a trailblazing technology leader, Ms. Katz has not only demonstrated remarkable leadership, but has also been an influential force in advancing endometriosis awareness and care. Her commitment goes beyond the corporate realm as she actively contributes as an advisory board member for Worldwide EndoMarch and the American and Global Congress of Endometriosis Subspecialists, emphasizing the importance of advocating for those affected by endometriosis. Recognizing her exceptional dedication, we are honored to present Ms. Safra Katz with the 2024 Endo Hero of the Year Award. The accolades acknowledges her substantial contribution to endometriosis community, and we look forward to hearing her insights.
Hello, everyone. I am so thrilled to be here today and to take part in the Worldwide EndoMarch once again. After my own surgery, I participated in that very early EndoMarch in Washington, D.C. And for those of you there, you'll remember what an incredibly cold day it was, but we wanted our voices heard, and they were. This organization means so much to me, and I am very proud of the important work that all of you do. It has been wonderful to be part of the advisory board and to see firsthand the important impact EndoMarch continues to make on how endometriosis is diagnosed and treated. My passion for healthcare spans not only this wonderful organization, but even my day job at Oracle. Healthcare is so important and such a critical part of everyone's life around the world. And the opportunity to create a more effective and efficient system that improves patient care is immense. Endometriosis, in particular, is so misunderstood and so often misdiagnosed. That is why this organization is so important. The impact EndoMarch has made on awareness and policy in more than 60 countries around the world is a testament to the dedication of the leaders and the members of this wonderful organization. All of you are making a huge difference. I'm so proud to be part of this community, and I know that all of you work so tirelessly to help hundreds of millions of people around the world. By raising awareness and sharing all of your powerful stories, we will continue to influence change and help those suffering with endometriosis. No longer should they be misdiagnosed and suffer in silence. This is incredibly important work. I am also excited about EndoMarch's work with the American and Global Congress of Endometriosis Subspecialists. This organization's work to bring together endometriosis experts and provide them with training and resources is key to addressing the urgent need of patients worldwide. And finally, I am honored and frankly humbled to have been selected as the 2024 Worldwide Endometriosis March Hero of the Year. There are so many heroes, and thank you. It is too kind, and I so appreciate this recognition. It is such a privilege to be part of this organization and to be here with all of you. Thank you for your work and dedication to this critical cause. I look forward to a great year ahead.
It is with great honor that I introduce our next speaker, the incredible Tara Lipinski. Beyond her celebrated achievements as a gold medal figure skater, Tara is here today not only as an accomplished athlete, actress, and sports commentator, but as a patient and a courageous voice in the endometriosis community. As the host of the podcast Unexpecting, Tara intimately shares her ongoing 5-year journey to motherhood, navigating the complexities of endometriosis-related infertility. Her openness extends to discussing her personal experience with endometriosis, shedding light on the challenges faced by many. Alongside her husband, Todd, and their beautiful daughter, Georgie, Tara's story is one of the resilience and hope. We are truly privileged to have Tara Lapinski join us during the virtual EndoMarch conference, sharing her insights and bringing a powerful voice to the conversation about endometriosis. Thank you very much again, Tara.
Hi, I'm Tara Lipinski, and I am so excited and honored to be speaking on behalf of EndoMarch. I am an Olympic figure skater who won the Olympics in 1998, and now I'm a broadcaster for NBC for the Summer and Winter Olympics. And most recently, I came out about my own personal fertility journey over the last 5 years and my own struggle with endometriosis. And that podcast I did with my husband, Todd Capastaci, it's called Unexpecting if you want to check it out. But I'm just very excited to be able to talk about my experience, and the podcast has been an amazing outlet because I've realized how many people are listening to what we're talking about and realizing that their symptoms may also mean that they have endometriosis. And it's sometimes so alarming for me to realize that so many people still don't have the information needed to go to their doctor, to find the diagnosis, to get treatment, to hopefully get to the doctor who's an excision specialist who can offer them hope, could offer them a life that has a lot less pain, and especially in a journey that might be similar to mine that could affect their future family building. And to give you a little background about myself, I probably have had symptoms for 12 years. It took about 10 years to diagnose. And that to me is still so mind-blowing that these pains that I was having and going to the doctor and trying to find answers, it just became part of my life where I thought, oh, I live with this. This is just a strange pain I get. And this is just a symptom that I'm meant to live with because I have a menstrual cycle. And I think that it is so important for people to be able to find experts, to find excision experts. There's so many times that I hear stories and people writing me that they actually did discover that they have endometriosis, and they got the diagnosis through a surgery that wasn't from an excision specialist, and now they're on their third surgery and they're still searching for answers. And there's just still so much to be done in the space to help people find a better quality of life when it comes to pain from this debilitating, sometimes debilitating disease, and to offer hope to people that, again, like myself, are on a fertility journey where endometriosis could be the reason that their family building process is delayed or they're dealing with loss. And for me, I've become so passionate about it because when I finally did get my surgeries, and Dr. Najat, who is my hero, literally my hero, and I realized walking away from these surgeries, how my life changed so much for the better, how the pain was greatly diminished. And for me, what was so exciting was my path towards building a family was greatly affected. My cycles through IVF, I think so many people who have endometriosis are going through IVF and they may not realize that the endometriosis is affecting that journey, the length of the journey, the success of the journey. And for me, after my surgeries, I had such great success. And just to give you a little tidbit about that, not to get too in the weeds about my journey or about IVF, but I think I always say it, and I said it on the podcast, that having the correct diagnosis, having a specialist that is Dr. Najat, someone like Dr. Najat, who is an excision specialist, was able to change my path dramatically. I went through 3 failed IVF egg retrievals, and after surgery, both times I did it, my results were double. I got 6 genetically normal embryos in 1 cycle, and there is no coincidence that was not from that surgery. And it really is just for me such an honor and a privilege to try to spread awareness wherever I can, to try to direct people to the right surgeons, to the right people that can finally diagnose them. And it's crazy to think that it takes so many people, maybe 10 years, to get that correct diagnosis. And then, like I said, we don't even know what treatment they are getting, and are they getting the gold standard. And for someone who's dealt with endometriosis and knows that pain very well, that is my biggest hope, that we are able to become a world where someone struggling with endometriosis has all the information they need, has everything at their fingertips to improve the quality of their life. And I am privileged and lucky that I have been able to find doctors to help me on this path, but that's not always the case. And thank you for all the work that you're doing. You're making the biggest impact, and you are changing the world of endometriosis. And I'm just so grateful and thankful that I've been able to be a very small part of it. And on my podcast, I promise I will continue to spread the information, the right information, and hopefully more and more people will be directed to the care that they need. I just want to say thank you to everyone. I obviously have to give a little shout out to Dr. Najat, because like I said, he is my hero. He has changed my world. I now have a little girl named Georgie who came through surrogacy, and I couldn't be more over the moon in love and been waiting for this moment. And it was a long 5-year wait, and endometriosis played a huge part of that. And I was able to find doctors who really helped me on this journey. I had 2 endometriosis surgeries, one with Dr. Orbuck here in Los Angeles and one with Dr. Najat. And I will probably be back to Dr. Najat very soon to do a last minute cleanup just for my own quality of life beyond fertility. But I'm just one of the lucky ones who's been able to move forward, and I hope that I can help in any possible way that I can. So thank you for letting me speak on this. And again, thank you for the work that you're doing.
Hello, I'm Rebecca Flicht, and I'm here representing fertility specialists who focus on the intersection of endometriosis, endometriosis surgery, and infertility. I wanted to express my gratitude to the organizers, to Dr. Najat for inviting me, and to the members of the ACGES Congress for including me in your program and allowing me to speak on this topic that I believe is of critical importance, not just for me, but for the many women with endometriosis that I treat. This is the concept of fertility preservation in women with endometriosis. And although we are very far from the goal of primary prevention of endometriosis, we do have opportunities to get ahead of the fertility impact, which far too often accompanies the disease itself. Knowing that women with endometriosis are a population that's at increased risk of infertility, I'm here to share that we can absolutely do better in preventing infertility for this at-risk group of women. None of us would be here speaking at this event if endometriosis was not a common condition in women. However, the 10% that we normally see in a general population can be dramatically higher, as high as 30 or even 50% in women with infertility. Of course, infertility is only one of the whole system manifestations of endometriosis that you see on the right of the slide, as we are increasingly recognizing that endometriosis is a whole body disease. To give a sense of how significant the effects of endometriosis are on fertility, consider that a diagnosis of endometriosis means that monthly fecundity rates fall from a baseline of maybe 20 to at best 25% in a healthy young reproductive population to as low as 5 to 10%. The reason why and how endometriosis can cause infertility may vary by patient, but commonly cited factors include distorted pelvic anatomy, the creation of an inflammatory environment in the pelvis, changes in egg and embryo quality and quantity that accompany endometriosis, and impaired uterine receptivity for early embryo implantation. Recognizing that surgery is often a very necessary part of endometriosis care, both patients and practitioners should be aware of the fact that while in some cases surgery can improve fertility potential, endometriosis and endometriosis surgery can both cause decreased ovarian reserve as well as adhesion or scar tissue formation in the pelvis, which then worsens the problems for women with fertility. The fact is that we should be talking about fertility goals and fertility problems for women with endometriosis. And to go one step further, we really need to begin to incorporate a discussion of fertility preservation options for our patients at greatest risk. When speaking about fertility preserving methods, we need to include options for the freezing of eggs, embryos, and also now ovarian tissue. The surgical procedure with the greatest impact on ovarian reserve is the removal of endometriotic ovarian cysts. And you see on the right a really good example of how these look on ultrasound at the top. And then we speak often about the sliding sign, which is the inability of a stuck ovary to move past the back surface of the uterus when we apply pressure with the probe. And you can just see on the bottom how that cyst is stuck right there. So thankfully, these cysts are easily identified. You can see it right there prior to surgery on imaging. And that means that there's plenty of time to talk about potential impact of surgery way in advance of the planned procedure. So although I know that other speakers are going to talk about techniques that we use to minimize trauma to the ovary and decrease the impact on ovarian reserve and function, this slide is here to really underscore the point that that when we remove endometriomas, we decrease AMH levels and we decrease the ovarian reserve. Now, AMH level is the measure that we use to represent the pool of fertilizable eggs in the ovary. And we also recognize that AMH, or anti-mullerian hormone, is now the main marker of ovarian reserve used by fertility specialists around the world. Interestingly, although there's a lot of studies that show that AMH levels clearly decrease after surgery, there are now, and this is a silver lining, studies that show that it does seem to slowly rebound as we get into the months and sometimes even years after surgery. Another key concept is that AMH is absolutely not a fertility test. So, for example, a low or a high AMH does not predict, with or without IVF, the chance that any woman is going to actually get pregnant that month. And that includes women with endometriosis. So even though we know that the numbers go down, we don't know how clinically significant these decreased AMHs that we see after endometrioma removal are for the women that have endometriosis surgery. The other thing to know about AMH is that it does give an idea of how long the reproductive lifespan might be and how many eggs and embryos a woman may make when undergoing IVF. So when we think about the scenario of endometrioma removal followed by IVF, which happens sometimes, it can give us an idea using AMH of what the expected yield would be from IVF in terms of the number of eggs. Most studies of endometrioma removal and ovarian reserve, again, have shown this decline in AMH that's seen after endometriosis surgery, mainly when we remove endometriomas and especially when we remove endometriomas from both ovaries. These women can be considered to be of the greatest risk when we talk about our discussions of fertility preservation. So always remember, endometriomas in both ovaries, those are your at-risk patients. In addition to mechanical injury that often occurs as we strip out the cysts where inevitably ovarian follicles are removed, there is also injury that results from electrosurgery that we use to gain hemostasis or control bleeding during the surgery. So everybody who does these surgeries knows that especially as we near the hilum of the ovary where the blood supply comes in, we can encounter bleeding. Although sutures and hemostatic agents are preferred, energy such as bipolar, monopolar, laser, plasma jet can be used. And when we are aware of the effects of these on decreasing ovarian reserve, we should be very conservative in using these measures. Now, in thinking about when and whether to operate on patients with endometriomas, I would caution that whenever we consider removal of bilateral endometriomas, we should be thinking about the impact on the ovaries. And we should also be considering whether it's a repeat surgery or if the patient is actively trying to conserve. to conceive, as it has definitely been shown that endometrioma excision prior to IVF is generally not indicated unless there is a large size to the endometrioma with big concern for spillage or access, meaning we just can't get to the part of the ovary we need to for an egg retrieval. So what do we do for an infertile endometriosis patient who's trying to conceive? Well, despite everything that I just said, sometimes surgery really is the answer. Although the yield is modest, surgery for stage 1 or stage 2 endometriosis has been shown in studies to improve clinical pregnancy and live birth rates. So while surgery might have a benefit for infertility in some cases, the data largely show that for women with stage 3 or stage 4 disease, if reproduction is really the goal, they may be best served by moving straight to IVF. If pregnancy is the goal, it's a different path. Obviously, if there's pain involved or concern for malignancy, that's a different story. It was previously common practice to remove endometriomas greater than 3 or 4 centimeters in preparation for IVF. This practice has largely been abandoned given the more recent data that it does not seem to improve pregnancy or live birth rates with IVF, and it does subject those women to additional surgical risk. Again, as I said, if pain or malignancy is a concern, or if the endometrioma is a large size, so for me, that's a 6 to 8 centimeter range, this can change the equation about whether or not to do surgery before IVF. Another interesting area, which unfortunately I can't go into in much detail today, is whether deeply infiltrating disease affects uterine receptivity and embryo implantation. This is a really fascinating question with no clear answer at this moment. At present, in my practice, I'll offer surgery for deep disease for patients with recurrent implantation failure. They've transferred multiple good quality embryos without success. And they haven't gotten there with other options and other protocols because, as everyone here knows, surgery for deep endometriosis has a significantly increased risk of complications. It's important to remember that IVF is not for everyone. And for some patients, there's a personal, religious, theoretical concern with IVF. In these cases, even with advanced disease, surgery might be the best option for them to achieve an unassisted pregnancy. So hopefully at this point, I've made the point that endometriosis affects fertility. But unfortunately, the treatment of endometriosis, especially surgery, also may affect fertility. So how can we do better for women that we know are at risk of fertility problems down the road? Well, although the concept of fertility preservation, which is banking of reproductive tissues, originally emerged from the cancer literature, we know that chemotherapy and other treatments for cancer can be harmful to the ovaries. We've begun to apply this concept to women with benign conditions like endometriosis as well. The most important principle here is understanding the impact of ovarian aging on fertility outcomes. So for those of us that do IVF every day, forever and ever, the best predictor of who's going to become pregnant is their age. So most of us can tell you that we would rather have young eggs, even if they're small in number, versus older eggs. And that decline in egg quality and quantity probably happens sooner than you might think, with changes noted as early as the middle 30s. So IVF does not change the quality of a person's eggs. There's literally nothing that we can do about that. And we see that played out over and over again in the changing success rates as women undergo IVF from 30 to 35 to 40. So therefore, frozen eggs will generally only do well or only do as well as the age at which we froze them. So the ideal egg freezing patient is going to be younger than 35 and is going to freeze hopefully up to 20 eggs in 1 to 2 rounds of IVF for ideal success rates. Because AMH does predict how many eggs we're going to freeze in a given round, and surgery does reduce AMH, it is most successful and most cost effective if you can freeze eggs before that big surgery that's going to reduce their AMH. As many fertility specialists, unfortunately, no longer perform endometriosis surgery, it's very important that the surgeon and the fertility specialist are communicating and collaborating very carefully to make sure that we're getting the best possible outcomes for our patients, thinking not just about now, but about their future reproduction. So although it's much less commonly used, ovarian tissue freezing, so not eggs, not embryos, but actually pieces of ovarian tissue, is a really good option for women who are undergoing endometriosis surgery. This was classically used for cancer patients, and we would remove an ovary or a portion of an ovary to freeze tissue for future use. And that can be also applied to patients who are at risk, including endometrioma and endometriosis patients. I usually use this only if egg freezing or embryo freezing is not an option. It should be noted that the ASRM lifted the experimental label from ovarian tissue freezing due to demonstrated successful and healthy live births using this technique. Now, it should be said, there's fewer than 200 live births from this method worldwide, so nothing compared to egg freezing and embryo freezing. When the ovarian tissue is thawed and reimplanted, the normal process of ovulation typically is restored within 3 to 4 months with no medications. Half of the pregnancies that have been achieved through ovarian tissue freezing have actually been natural conceptions without the use of IVF. So with this in mind, ovarian tissue freezing would be a particularly good option in the setting of endometriosis or endometriomas for women who, don't have other options with IVF, egg freezing, or embryo freezing. That said, it really hasn't been well studied. More research is definitely needed before this is a mainstream option for this particular population of women. So who to offer fertility preservation for? Unfortunately, there's still no national guidance, no consensus guidelines for fertility preservation in endometriosis patients. So even if you've listened to this lecture and you agree with me philosophically, it doesn't really leave you with a clear strategy. So for this reason, in 2019, we published an algorithm that hopefully will be helpful. And this was based on known risk factors, optimal ages for freezing eggs and embryos, and measures of ovarian reserve like AMH. And the only comment that I would make about what you're seeing on the slide would be that normal ovarian reserve is really not easy to define and might depend on your local AMH assay or other factors like long-term birth control pill use. So for my purposes, although we used to consider greater than 1 to be normal, I now consider normal ovarian reserve to be above 2 when I'm thinking about individuals at risk who need fertility preservation. So also in this graph, observation is suggested for women 36 or younger that have a unilateral endometrioma, no previous surgical history, in line with the fact that the best age to freeze eggs is really probably 32 to 34. I now recommend observation only for women that are clearly younger than 35, so 34 and below, who have normal, and for me that's 2 ovarian reserve. Now, for the most important slide, how do we do it? Well, that part is actually easy. We do it together. We do it by asking women who have known or suspected endometriosis about their reproductive goals as early and as often as we possibly can. Do you want kids? If so, when? How many? Did you always imagine having a large family, or have you always just wanted one child? Women actually desperately want to be asked these questions by the doctors that are caring for them. As many women, especially younger women with endometriosis, can conceive without assistance, prevention of infertility related to endometriosis can be as simple as saying to a young patient with the disease, hey, you're at risk, rather than waiting for the perfect time in 5 years, 7 years, 10 years. When you're in a position to do so, try to start conceiving as soon as possible, knowing you have endometriosis. Your road's going to look different. Infertility might become part of your picture. So back to the question, how do we do it? We do it together by making sure that women are fully informed about their diagnosis and how endometriosis and endometriomas affect fertility. We do it together by offering fertility preservation when appropriate prior to surgery. And we do it together by making sure that when surgery is needed, our endometriosis patients have their surgery performed by experts in tissue handling, as studies have absolutely shown that experienced surgeons remove less healthy ovarian tissue. And finally, clearly, we need more data to guide patients in shared decision-making and possibly decisions about fertility preservation. We need studies that look at cost, insurance coverage, more than what we can cover in this lecture. But as we've made strides in coverage for the cost of egg freezing for other diagnoses that threaten fertility like cancer, my hope is that we can begin to advocate for our patients with endometriosis so that egg freezing, embryo freezing, or ovarian tissue freezing can be offered to women who have the common consequence of infertility, and perhaps even avoid these risks by offering them as fertility preservation methods. So thank you for taking the time to listen to this discussion about fertility preservation in women with endometriosis. And again, my gratitude to the organizers for putting together this terrific conference. Thank you so much and have a great day.
Hi, I am Marcello Ceccaroni, Director of the Department of Obstetrics and Gynecology, Gynecologic Oncology and Minimally Invasive Pelvic Surgery in Negrar, Verona, Italy. Our center is a referral center for deep endometriosis and GYN oncology cases, collecting the worst cases of deep endometriosis from all over the country and even from outside the country. Deep endometriosis is a terrible and dramatic and challenging disease affecting the body and the soul of a woman, interacting with her personal life, private life, social lives. Any kind of interaction is dramatically worsened by this kind of disease, affecting also the possibility of pregnancy, expectation, and desire. So when a woman is affected by deep endometriosis, is not affected only the woman, not only her body or soul, but also all the people interacting with her, including the society. For this reason, it's a social disease. And for this reason, all over the world, in these incredible events that both patients and doctors are organizing all over the world, the consciousness and the awareness of this disease is getting better, and it's improving year by year. We have to widespread the information to the young generations, and we have to widespread this information not only to the common people who will interact with a potential patient as a husband, as a friend, as a relative, but also with the doctors who needs to be more skilled and more trained in realizing the symptoms of this disease many years before, so avoiding that the disease can go ahead and growing, worsening the life of the lady, but also infiltrating massively all the pelvic organs and the pelvic viscera. In fact, deep endometriosis is a disease that can be supported and treated by medical treatments, but we estimate an average delayed diagnosis all over the world from 7 up to 10 years, which means 14 periods more or less per year, which means 140 average fires that in the abdomen and in the pelvis of the lady are occurring. So in many cases, there is no possibility to trust in the medical treatment because they are not helpful anymore to treat the symptoms and to improve the quality of life. For these reasons, in a very important group of patients, there is the need of a surgery. I work in a referral center for deep endometriosis surgery, and just for giving you an example of the numbers, we manage more or less from 13,000 up to 15,000 patients per year, and 1,500 of them receive surgery, which means that normally we yearly treat the 10% of them. But these 10% of ladies had a really bad history of disease and need very radical and multi-visceral surgeries, which means many times requiring radical hysterectomy with no possibility to conceive, or bowel resection, bladder resection, major ureteral surgery, diaphragmatic resection, because this disease is growing and spreading and stretching and compressing all the pelvic viscera. So for this reason, the ultra-radical procedures that are multi-visceral, many times that are performed, have been burdened along the years by several rates of pelvic dysfunctions. In fact, for giving the radicality surgically to the lady, so removing all the disease and with excision of the disease, many times this disease is infiltrating also nerve fibers. These nerve fibers, which are called ortho and parasympathetic fibers, which are called fibers belonging to the visceral pelvic system, are fibers that are modulating the pelvic functions, such as bladder and rectal motility, continence of bladder and rectum, and what we call sexual arousability, which, according to the DSM classification, is the ability to attain and maintain an adequate response of lubrication and swelling of genitalia all along the intercourse. So all the neurovascular reflexa that are modulating the lubrication and swelling. So which means after this surgery, a worst quality of bladder, rectal and sexual life. All along the years, more or less in the last 20 years, many techniques have been developed for ensuring a radicality of the disease, also in front of multivisceral resections, but in the same time trying to spare the nerves. So stealing many surgical steps from the oncological procedures that have been developed along the years for rectal cancer or prostatic cancer or cervical cancer as well, many nerve-sparing procedures have been developed and proposed for other type of diseases and also for deep endometriosis surgery, which is really a challenging disease from the surgical point of view, because it's even worse than the cancer, not biologically speaking, because it's a benign disease, but for the modality of infiltration, growth of the lesions, and all the fibrosis surrounding the tissues. So basically, I can say that the nerve-sparing procedure and the nerve-sparing philosophy is a way for facing anatomically the surgical field, and in the same time for removing all the disease, so giving radicality, but in the same time sparing the majority of these nerve fibers, thus preserving and protecting as much as we can the pelvic functions, thus reducing the pelvic dysfunctions after the surgery, then improving the quality of life of the lady. These nerve-sparing techniques are something similar to what we can imagine when we see the video about the big buildings that are imploding. They are imploding, but this implosion keeps the other surrounding buildings intact. More or less, the philosophy of nerve-sparing surgery is this one. We developed a proper technique which is called the Negrar method, which is a nerve-sparing laparoscopic, so minimally invasive, eradication of deep endometriosis with rectal and or parametrial resection, which are the ligaments around the uterus containing the fibers, the parametria, according to this nerve-sparing philosophy and technique. There is a proper technique, in this case it's called the Negrar method, because Negrar is the city of Verona, close to Verona, where the hospital is placed, our hospital. And in 2012, we proposed this technique with a prospective study comparing the classical procedure to the nerve-sparing Negrar method procedure. Of course, the results were dramatically impactfully in favor to the Negrar method. Just for giving you an idea, with the classical technique, the average of severe pelvic dysfunctions after radical treatment for deep endometriosis was 36%. Of course, with the range going from the 15% up to 64-65%. With the Negrar method, so with the nerve-sparing approach, these dysfunction rates were lowered at less than the 6%, which means that just working and thinking strategically in the proper anatomical way, we, not only our center, but many other centers in the world along the years, have been able to reduce the neurological impairment and the surgical ablation of these nerves, which means to spare the functions, but this means also to impact very concretely and very dramatically, in the good sense of the term, in the quality of life of the patient, which means pelvic dysfunction for a lady means painful intercourse, no intercourse at all, rectal atony with the need of enema every day for having a correct and proper rectal function, or it means to use an intermittent self-catheterization every 2-3 hours for all life. So these nerve-sparing procedures were able to reduce this rate of dysfunctions and the number of patients with dysfunctions. Of course, I think personally, but it's my opinion, that it will be quite impossible to reach the 0%, surgically speaking, because we are speaking about fibers, nerve fibers, which are already infiltrated by the disease. And so with these anatomical tips and tricks and strategies, we were able to reduce this dysfunction, minimizing the number of fibers which are sacrificed. The only way for getting a 0% is the cultural revolution in having a better perception of the disease, a better awareness of the disease all over the society. So from the high school to the families, to the normal interaction that we have every day, a better awareness in the doctors, the general physician and the specialists, in order to have and to get an early detection of the disease, a correct and proper diagnosis, in order to treat these ladies properly and in time, very early, with medical treatment, avoiding, in this case, the surgery. And to avoid the surgery means to avoid the risk of damage of some fibers, but avoiding the surgery means that the lady is so good for an early detection of the disease, for an early diagnosis, that she doesn't have a huge and bulky disease and a huge infiltration of the viscera. So the only way for curing endometriosis is the culture. And this cultural revolution is also brought not only by papers or congresses or scientific events, but also by this world awareness campaign. And I'm very thankful to all the associations of patients worldwide. I'm very thankful to my friend Kamran Nejat with his group, outstanding group, for spreading this culture and this awareness all over the world. So from the deep of my heart, I wish you an incredible awareness campaign this year. And we have to fight endometriosis, but the best way for fighting endometriosis is spreading culture and spreading awareness. Bye-bye and ciao from Italy.
Hi, my name is Stacy Young. I completed my OBGYN residency at Parkland in 2017 and my fellowship with Dr. Najat in 2018. I've been in practice for about 6 years post-fellowship, both in private practice and now at an academic hospital. I decided to pursue a fellowship in minimally invasive gynecologic surgery because I wanted to improve my skills in managing advanced minimally invasive surgery cases and difficult endometriosis. I learned a lot about endometriosis in my fellowship, particularly the difficulty patients encounter getting physicians to listen to them and believe their pain. We frequently hear that patients are told their symptoms are normal or that it's just in their head. The typical presentation is a patient who has gone 10 or more years and seen numerous doctors without a diagnosis. They describe the physical, emotional, and psychological relief when they finally find a physician who recognizes the diagnosis of endometriosis and validates their experiences as real. This insight has led me to approach endometriosis patients with a deeper level of compassion and empathy, as well as highlighting the importance of educating physicians on the variable presentation and severity of this disease. Endometriosis does not always present in the classic way with painful periods, and the severity of symptoms does not always correlate with the extent of their disease. I hope that by talking openly about endometriosis in the scientific and patient community, continuing research in this area, and sharing patient stories, more patients and physicians will have the knowledge to recognize the signs and symptoms of endometriosis early and be able to manage this chronic and debilitating disease earlier and more effectively. Thank you.
We are here today in Washington, D.C. at the Capitol Hill, really, and we are meeting with state representatives as well as elected officials and letting them know that there are 8 to 10 million individuals nationwide suffering with endometriosis and the chronic comorbidities that come along with it as well.
We are trying to come together to just combat this, give patients help and hope, get some real change.
We're here today just to advocate for those many women who have been misdiagnosed or not diagnosed at all and suffer silently. The ones that can't make it out of bed because they're hunkered over in pain in their beds and can't get up or can't eat or take care of themselves enough to even work up the energy to advocate for themselves. That's where I stand. That's what I'm here for.
My name is Togas Tulandi. I'm the chair and professor of obstetrics gynecology at McGill University. I'd like to thank Dr. Nezat for inviting me. The topic is lessons from extrapelvic endometriosis. This is where I work. I'm from McGill University in Montreal, in Canada. And this is where I do my clinical work at McGill University Health Center. This is a conglomeration of several hospitals under McGill University in Montreal. The left-hand side is the research institute, the middle is the adult hospital, and the right-hand side is the children's hospital. You don't see it at the most right is the orthopedic children's hospital. This is my disclosure. I'm the editor-in-chief for Journal of Obstetrics and Gynecology of Canada. I'd like to congratulate Dr. Nezat for developing an entity called Access. I think it is important for all of us who are interested and passionate in endometriosis. We created an EndoCares, which is Endometriosis Center for Advancement in Research and Endometriosis Surgery. And these are the core people who are manning the EndoCares. We call it endometriosis surgery, but it's not just surgery. We are also doing basic research. If we talk about pathophysiology of endometriosis, the answer is we don't know for sure. But there are many theories. One of the theories is the oldest theories is by Sampson. It's called retrograde menstruation. So with each period, the blood and endometrial cells going up into the fallopian tube and into the peritoneal cavity. In women with no endometriosis, those cells will disintegrate. Maybe it's related to a self-defense mechanism of the patient. So the cells will go away by the process called apoptosis. In women with endometriosis, they don't have that self-defense mechanism, so the cells will grow. They'll undergo angiogenesis, neurogenesis, and spread. Other theories are hematogenic spread, lymphatic spread, coelomic metaplasia. Immunologic theory, maybe the immune system in women with endometriosis is impaired. The new theory is a systemic disease altering gene expression. Talking about gene, we found that 8% of Montreal women have familial endometriosis. They have somebody in the family with endometriosis. The same percentage was found in UK by Stephen Kennedy, about 7-8%. So genetic factor might play a role, but certainly could also be multifactorial. I mentioned that the blood goes inside the fallopian tube with each period. This is the proof. Every time we do a laparoscopy during period, we'll see blood in the abdominal cavity. So it's very common. It doesn't mean that this is the cause of endometriosis. This is the new theory, and Dr. Taylor from Yale has done many studies in animal model, and he found that endometriosis might be caused by systemic inflammatory disease. The pain that the patient experience might be also associated with inflammation. We did some epidemiological studies And this is just the papers that we published in past 3 years in relation to endometriosis. We recently found that endometriosis is associated with Raynaud syndrome. The Raynaud syndrome is affecting blood vessels. It might be related to inflammation. We also published a paper that there is an association between endometriosis and preeclampsia. Also, this could be related to blood vessels and inflammation. So let's just talk about the first case. Our first case is a 29-year-old African-American woman with infertility. She had abdominal pain, cyclic abdominal pain. On examination, she had an umbilical mass, tender umbilical mass, and she said it's very painful during the period. So what are the differential diagnoses? Well, the first one is keloid. She is African American, tend to have more keloid. But she never had surgery on the umbilicus, never had the belly ring. So it's not keloid. How about Sister Mary Joseph nodule? You might not know Sister Mary, but Sister Mary was a nun and also a nurse. She looked after a surgical center, and she realized that men and women with abdominal cancer, sometimes they have a nodule at the umbilicus. So the surgeons called it Sister Mary Joseph nodule. Our patient has never had surgery. She has no symptoms of cancer. She is healthy otherwise. So it's not Sister Mary Joseph nodule. So how about umbilical endometriosis? It's possible. Usually secondary after laparoscopic surgery. And if you don't remove the tissue using a bag, the endometriosis cells might contaminate the abdominal wall, and endometriosis might develop. Our patient never had surgery, so must be primary umbilical endometriosis. Sure enough, we did an ultrasound. She had a 4-centimeter endometrioma. At surgery, we found that that lesion that we saw outside is just the tip of the iceberg. The lesion is much bigger under the abdominal wall. We excised it, and we also excised stage 4 endometriosis and endometriomas. She didn't want to wait, and she went to IVF. So our lesson here is extrapelvic lesion suggests the presence of pelvic endometriosis. This is the pathophysiology of the tissue that we removed. So our question is, which one is the causes of endometriosis? Most likely in this case could be anything actually, immunologic, multifactorial. So we'll just carry on. What's the implication of keloid? Well, this is in passing. I just want to mention that we did a study looking at all women with keloid, and women with keloid tend to be having intra-abdominal adhesions. More dense actually than women with no keloid. It's more common in African Americans, could be Asian. White is less common to have keloid. We also found that endometriosis tend to occur on the left side. It's not just we, but also Dr. Vercellini from Milan in Italy found that endometriosis tend to occur on the left side. We thought this is related to the movement of peritoneal fluid. Peritoneal fluid moved from the left pelvis, going up under diaphragm and back to the right paracolic gutter. On the left side, you have sigmoid colon. So the movement of the fluid is delayed on the left side and allowing the endometrial cells to stay longer on the left side. We thought that could be the cause of why endometriosis tend to occur on the left side. Let's go to case number 2. 34-year-old woman has this cyclic dysmenorrhea in dyspareunia, and she had right chest pain with each period in the last 12 months. She had a history of pneumothorax treated with a chest tube. This is the X-ray. In this case, the pneumothorax tend to occur. It was found on the left side. She underwent video-assisted thoracoscopic surgery, and the surgeon biopsied the pleura and found findings consistent with endometriosis. I did laparoscopy, and she was found to have stage 3 endometriosis, and we excised all this endometriosis, and she conceived 6 months after surgery. The lesson here is catamenial pneumothorax suggests the presence of endometriosis, pelvic endometriosis. Catamenial means related to the period. In this case, she had pneumothorax with each period in the past 12 months. You can also have catamenial migraine, in which somebody has migraine each time they have period. Catamenial epilepsy, they have epileptic attack during period. In this case, our case has catamenial pneumothorax. This is the hemosiderin on biopsy. We look at the relationship between catamenial pneumothorax and endometriosis and compare it to those with non-catamenial pneumothorax. We collected data of 21 women with catamenial pneumothorax and 21 others without pneumothorax. When we published it, this was the largest series in the world. So again, 21 women with pneumothorax during period, with each period, and 21 others without relation to menstrual period. We found right pneumothorax in 95% in the study group. Study group is those with catamenial pneumothorax, and 50% in the control group. In 2 cases, we found complete collapse of the lung on the right side. And most cases had apical pneumothorax. The control group has no thoracic endometriosis whatsoever, but the study group has 60% thoracic endometriosis, and we also found 94% of them had pelvic endometriosis. This is again 95% patient with catamenial pneumothorax has mainly on the right side, 57% in non-catamenial pneumothorax. Endometriosis on biopsy, 60% in those with catamenial pneumothorax and none in those with non-catamenial pneumothorax. Again, right pneumothorax is predominant in women with catamenial pneumothorax. Over a half of women with catamenial pneumothorax have thoracic endometriosis. So it seems like endometriosis plays a role in the pathophysiology of catamenial pneumothorax. This is just to show you that we published also a systematic review on catamenial pneumothorax. This is a diaphragm. We can see a small spot of endometriosis here. Most importantly, over 3/4 of women with catamenial pneumothorax have diaphragmatic endometriosis. This is a more pronounced endometriosis on the diaphragm. It's 95% on the right side. We ask again, what are the possible etiology of endometriosis, of the diaphragm and of the lung? Well, let's go back to the peritoneal fluid movement. Peritoneal fluid movement, the peritoneal fluid moves from the left side, goes up, all the way up under the diaphragm and back to the paracolic gutter. On the left side, we have sigmoid colon, delaying the movement of the fluid. Endometrial cells tend to stay longer on the right side. That might explain the left lateral predisposition of endometriosis. The peritoneal fluid move up here under the diaphragm. So the diaphragm is exposed to endometrial cells. The diaphragm on the right side has a larger surface than on the left side. That might explain why endometriosis of diaphragm tend to occur on the right side. But also, maybe more importantly, if you look at the diaphragm under the microscope, on the right side, it has more lacunae, more holes. So that also might explain why the endometriosis of the lung tend to occur more on the right side. Endometriosis of the appendix, well, is still in the pelvic cavity, so it might be just related to contamination of endometrial cells to the appendix. So we go back to our question. What is the pathophysiology of endometriosis? Retrograde menstruation is correct, but it does not explain why endometriosis developed. This is a very common phenomenon in women. So each period, you have retrograde menstruation. Hematogenic spread, it questions why it's not elsewhere in the body. Same thing with lymphatic spread. Coelomic metaplasia might explain why it happens in the abdominal cavity. Coelom is embryonic peritoneum, pericardium, and pleura. So in that case, why not in the pericardium? Immunologic theory might be correct. So women with endometriosis have a defective immune system, if you will. That's why endometriosis grows. Genetics, possible, maybe also related to immune system. Perhaps the most important etiology or possible etiology today is that endometriosis is systemic chronic inflammatory disease. That might explain that why preeclampsia, Raynaud's phenomenon, migraine tend to occur in women with endometriosis, or at least more often in women with endometriosis than in those without endometriosis. Of course, there's a possibility of multifactorial. Well, the pathophysiology of endometriosis remains unclear, but all those, the red one, is the possible pathophysiology. It is important to know the mechanism of endometriosis. If we do know the pathophysiology of endometriosis, the treatment could be more targeted, could be more focused, could be more effective. Further research is indeed needed. Thank you for your attention. And thank you again to the Nezat brothers for inviting me.
Hi, the subject of my talk today is how artificial intelligence is going to help endometriosis patients make their embryos better. First, I'd like to thank Kamer Najat who invited me to talk today, and I'd like to introduce myself. I'm Daniel Seidman. I'm the co-founder and the chief medical officer of IVF, a company that has successfully developed algorithms which can actually improve the likelihood of success in IVF patients through artificial intelligence. Now, I think the audience is very familiar with the difficulty in getting pregnant that is very prevalent in patients with endometriosis. In fact, some patients realize that they have endometriosis for the first time when they have a difficulty to conceive. So there's been a lot of research over the last several years looking on reasons why patients find it difficult in conceiving when they have endometriosis. What we realized is the problem is probably in the eggs and the embryos. Why? Because when you do egg donation in patients with endometriosis and you take eggs from patients who do not have endometriosis and implant them in the uterus of patients with endometriosis, you get terrific pregnancy rates, which means that the uterine environment doesn't have a huge adverse effect on the success rates. So everything is probably concentrated in the quality of the eggs and the embryos. And we know from research that there are characteristics of oocytes coming from patients with endometriosis, for instance, darker granulation, thicker zona pellucida, a higher content of mitochondria, and we're trying to understand why is this happening and how can we improve pregnancy rates. Now, I'm not going to make a deep dive into the basic science, but I'm sure most of you are familiar with the fact that the pelvis has inflammation in patients with endometriosis, and we know there are a lot of substances which are discharged into the pelvis, for instance, reactive oxygen species and various cytokines, and all these can adversely affect the egg and the embryo. We also know that the immune system works differently in patients with endometriosis. This is probably why the lesions flourish in the pelvis, and this change in the immune system can also negatively affect the development of the eggs and later on the embryos. And there are multiple ways this can happen. It can affect the oocyte meiotic spindle, it can affect the extracellular matrix, but in the end, we're getting embryos that are less likely to implant. Now, one of the big achievements in IVF over the last several years is the development of time-lapse incubators. In these incubators, we get videos of the first 5-6 days of the embryo development. So instead of looking at 1 or 2 pictures of the embryo, now the embryologist can look at almost 2,000 pictures, and this is generating huge amounts of information. And several studies have looked what happens in patients with endometriosis, and they found that patients with endometriosis have embryos that divide differently, the cleavage rate is different, and this, for instance, is a study from Nina Desai from Cleveland Clinic, and she has shown that embryos from patients with endometriosis are less likely to divide in an optimal manner. More information is also being generated from electron microscopy, where we can actually look at the mitochondria, the organelles that generate energy for the cell, and again, studies are showing that oocytes look different from patients with endometriosis. The problem is that in a clinical way, it's very difficult to look at these vast amounts of data generated from time-lapse incubators and to look into characteristics which are very difficult for the eye to follow. So using computer vision, which can follow things a normal embryologist cannot do, and developing AI algorithms, we at IVF are using computer vision to look at features in the embryo that cannot be followed by the human eye. For instance, we are able to measure cell borders of the cell as a proxy for cell activity, something a normal embryologist cannot do. Also, our AI algorithms can look at minute pixels, microns inside, as a way to actually measure mitochondrial density. So we don't need an electron microscopy. We can actually look at features that no embryologist has been able to observe before. And currently at IVF, we're taking videos from time-lapse incubators of patients with endometriosis versus videos from patients without endometriosis and trying to look at special features and the way they develop. Our AIVF score has been shown to be very well correlated with the way embryologists grade the embryos. And even more interestingly, actually, if you get high IVF scores, this can predict the likelihood of the embryo to implant. So we can really learn about the quality of the embryo through these artificial intelligence algorithms. One of the problems embryologists see every day is what to do when you have three great-looking embryos, high-grade embryos, which embryo is affected by endometriosis and which embryo is less likely to implant. And again, what we have shown is that the AI algorithms can actually differentiate between top-grade embryos and tell us which is more likely to end up in a healthy baby. One of our biggest achievements over the last year is that we've developed new algorithms that can differentiate between aneuploid and euploid embryos. This means embryos with normal chromosomes versus embryos with abnormal chromosomes. And as you know, currently many patients undergo PGTA, a very costly procedure, very invasive. You actually have to biopsy several cells of the embryo in order to tell you if the chromosomes are normal or not. So this is really a major achievement that now, non-invasively, using pictures generated from a time-lapse incubator, our AI algorithms can tell you if this embryo is more or less likely to be an euploid. And of course, the effects of endometriosis on the chromosomes will be evaluated using our new algorithms. So what does the future look? We are sure that we're going to generate a lot of information about the effect of endometriosis on the developing embryos. This is not only going to enable us to improve the chances of success by choosing the best embryos, but we can also look at study protocols and see which ways we can better treat patients with endometriosis in order to end up with higher quality embryos. So we really are sure that in the near future we're going to get much better perspective of the effects of endometriosis and also be able to improve pregnancy rates. I would like to thank the team at IVF. We have almost 50 experts working with AI trying to develop better ways to improve pregnancy rate, and I'm sure that patients with endometriosis will gain a lot of benefit from these new algorithms which are going to improve the way we treat patients with endometriosis at the IVF world. And again, I'd like to thank Cameron Najat for inviting me today, and I'm sure in the very near future you're going to hear more and more about the way IVF and these new technologies improve the world of IVF. We're currently installed in Europe, in Asia, now in North America, and I'm sure that you're all going to hear about the big achievements of this new technology. Thank you all.
Hi,
Hi.
Dr. Rene, we are so happy to have you here. And I know you, of course, but could you please introduce yourself at first? And maybe you want to talk about endometriosis?
Okay, sure. So first of all, thank you very much for inviting me to this wonderful event of EndoMarch 2024. I'm Dr. Mehmet Ünlü. I'm working in the Acıbadem University Hospital in Istanbul, Turkey, and as director of endoscopic surgery and endometriosis clinic. So, as you know, endometriosis affects 10% of women at fertile age, and it is not a single condition, often not a disease. Symptoms such as dysmenorrhea, dyspareunia, infertility, and stress can impair social, emotional, and physical well-being, and may even cause chronic pelvic pain in patients with endometriosis. As said by an endometriosis patient, you have many dreams when you are healthy, but only one if you are sick. The first approach to fight this disease is very important. Correct diagnosis, adequate counseling, multidisciplinary team, and individualized treatment are essential for success. Misdiagnosis, late diagnosis, and inadequate treatment cause worsening of the disease. In the treatment of this complex disease, the skill of the physician and expertise of the center play a key role. Yet many doctors do not have the necessary knowledge and experience to effectively fight this enigmatic disease. So this was also a common introduce of this of the endometriosis. Dear Elif.
Thank you. And would you like to talk about the endometriosis awareness in Turkey and the availability of the endometriosis specialists and surgeons here?
Of course, of course. As you know, I am the founder and the president of Turkish German Gynecological Foundation, and working for many years in this area. Actually, on the grounds of these facts I mentioned before, we have been providing a 4-level training to thousands of surgeons in our international conferences and workshops for more than 30 years, including hands-off workshops, simulated trainings, live surgeries, and the cadaver workshops. Besides, the Journal of the Turkish German Gynecological Association published for the last 26 years, and our atlases contribute to education of surgeons. Furthermore, we provide scholarships to young skilled surgeons to renowned and experienced reference institutions in Europe and in the US. I would like to take this opportunity to express my gratitude to Nejat brothers for the great contribution they have extended to many of young surgeons in years by hosting these training events in their institutions. On top of this, we have developed a unique 4 steps social responsibility project for raising awareness on endometriosis in smaller regions of Turkey outside the metropolitan areas. First, we gather all our women in a convention center and spend the day with them by making interactive presentations. Next day, we provide the similar training to all health professionals who works in that area. Then we perform endoscopic surgeries on all identified patients in the city. We teach advanced techniques to surgeons by live surgeries and by live surgery sessions. And finally, we donate a medical device that the hosting hospital needs. This is our unique project, and we every year and sometimes every 2 years, the overall pandemic has little bit negatively affected our activities, but we have started again to make this kind of educational activity in our smaller regions of Turkey outside of metropolitan areas.
It's so important to have the works in Turkey because we have so many little regions in our country that so many people, so many women just haven't get a chance to get in touch with specialists and surgeons and the medical devices even. So yeah, it's so important. Thank you so much on behalf of them.
Yeah, thank you. As maybe as a final remark, I would say that first of all, we have to really work hard to succeed in this fight against endometriosis. And we should exhaust all our energy and skills without being withheld by potential difficulties and by partial failures of life in life. This is only way we can challenge this enigmatic disease, endometriosis. Thank you very much.
Thank you.
And I wish big success to this year's EndoMarch 2024.
Thank you.
I'm Dr. Kamran Najat, the founder of the worldwide EndoMarch. Hello everywhere around the world. This is Dr. Kamran Najat, the founder of worldwide EndoMarch. I would like to welcome you to our webinars for the year 2021. This has been a great year so far for all the patients with endometriosis, as gradually, as you can see, more and more awareness meetings, publications, literatures, legislation around the world is happening. When we started worldwide EndoMarch 8 years ago, our mission was to raise awareness, find a method to prevent and diagnose the disease better, excuse me, I'm sorry, and also a good method to treat endometriosis. And these sessions has gradually gained what we are trying to do. There is no more people telling patients, coming to you and telling you, okay, it was in your head, you were imagining it. The awareness and diagnosis about endometriosis is increasing. Endometriosis is a whole body disease. It is not only a disease of the reproductive organ. We have been saying it since the 1980s. And also we have been saying that endometriosis is far more common than 1 in 10 patients who are female or born female genetically. And one of the issues about endometriosis is it could affect every organ. And we have had webinars before. Those of you who are interested, you can go on previous sections and look at www Worldwide EndoMarch and go on the top of the session and download the previous session, like endometriosis of the bowel, bladder, ureter, diaphragm, nerves, etc. You can find previous webinars and find them and download them for your information. Another issue is we wanted to find a way to diagnose endometriosis much cheaper, easier, and without a surgery. That is another one of the goals of Worldwide EndoMarch. Thank goodness, more and more tests are coming to the market that they are going to achieve that, so you do not, patient doesn't have to have surgery to diagnose her endometriosis that fast. Also, Worldwide EndoMarch has developed an app. It is called Nejat Endometriosis Advisor. That app is completely free all over the world. You can download it from the Worldwide EndoMarch, that Nejat Endometriosis Advisor app. It is on Apple and also on Google. You can download it and it would help you to at least give you some guidelines if you may have endometriosis, and if you are trying to get pregnant and you cannot get pregnant, all of your tests are completely normal. Your husband, your partner's and your husband's sperm count is completely normal. Your tests are completely normal. You are trying to get pregnant, and all of your tests are normal. The majority of you, in our opinion, may have endometriosis, and that app can also guide you towards your direction. If you are an adolescent, if you are a teenager, and you have killer cramp, you have very bad cramps, you have pain, and with your period, sometimes even not with your period, you can download that app and can help you. So since that, we often see in life that when a person is on a wheelchair and somebody is pushing that wheelchair ahead, we look at the person sitting on the wheelchair and we feel empathy and sympathy for that person. But we often forget about the person who is pushing and directing that wheelchair. And that is happening usually with the families of the patients who are affected with endometriosis. A lot of patients who have endometriosis, they have mother, father, brother, sister, children, and friends that they have to suffer with that patient, with the issues, being it pain, being it organ dysfunction, or being a very emotional issue of infertility. They are suffering with them too. And we thought we focus this session on those people who are pulling and pushing those wheelchairs that have to deal with the issues of their families when they have endometriosis. And we are very lucky. We have 3 families today that are going to address that issue. One of them is Alexis and Maria Rosemond. And Alexis is our patient who is going to talk about it with her mother and her family. And also we have Lily Cooper, who is familiar with you. You have seen her, and her mom, Karen, and her father, Edward, that they are going to be joining us. And also we have Taylor Avakian, who is a medical student now and has been a patient of ours, and also she has had endometriosis. She has been on the program, and her parents that they are going, Dina and Jean, that they are going to join us. And if any of you have any questions for these families, please ask them. And I would start with Alexis and Maria. And I just want to ask Maria that, and I want to thank them very, very much, immensely, enormously, for being so kind to join this program for the benefit of the families of other patients with endometriosis, to see how to navigate these roads. So I will ask first from Alexis and Maria to say hi, and I would ask Maria, how did you find out for the first time that Alexis had endometriosis?
Hello, everyone. And thank you, Dr. Nesjad, for having us. We went through over 10 years of doctors trying to find out what was wrong with Alexis, and were unsuccessful. It wasn't until we moved to LA, because we're originally from Florida, from Miami. And so we exhausted just about a lot of gynecologists in Miami trying to find answers, and many visits to the hospital. So it wasn't until we finally saw Dr. Nesjad, and it's been 2 years now, that she had her first diagnosis ever and treatment.
Thank you very much. How about now, I'd like to ask Lily's parents that the same question, Karen and Ed. How did you find out that Lily has endometriosis?
Well, after going from doctor to doctor to doctor to doctor without any answers, and often being told it was in her head, we actually just started researching online ourselves, and actually through a Google search, the word endometriosis popped up, and then having talked to somebody in our lives that had it, we were able to recognize all these symptoms really matched the description in every way, and was able to connect to you, Dr. Najat, which was a blessing. And then have you, just hearing her story, feel that it was extremely likely. And then through some testing and then the surgery, we were able to get a lot of answers for the first time in years, and through a very exhaustive search.
Thank you. So Jean, how about you and Diana? How did you find out about Taylor?
Well, with Taylor, she just had some major pains, went down to the ground. I know a local doctor here that runs the hospital, called him, got her in. They had her sit in the hospital for 7 days. They ended up taking out a tube and an ovary. And then they said, we need much later, about a couple months, because of all the pains and everything she went through. They said, we have to take out the other one. I had asked for infertility specialist, and she's the one who referred me to you. They had given me her sonogram to show the infertility specialist how bad her other ovary was. And the infertility specialist had told us that it was perfectly fine. There was nothing wrong with that, that they would never have to take that out, and that she needed to come and see you. And then you performed a 7-hour surgery, and she was tremendously better for years after that. Yeah.
So thank you. So, so finally, in your way, in your course of treatment, I just want Alexis and Maria, and you have the podium, just tell your story, Alexis. How are you dealing with the issues now? How do you manage, and what would you do differently and what is your advice for other people? In general, go ahead and say some story about your journey.
Yes. I feel like for many of endometriosis patients, there is a common thread. And listening to Lily's story and even Taylor's mom's story, it really was similar in that we suffer for so many years without ourselves knowing what's going on. And when we finally can start voicing what we're feeling to medical professionals, not feeling heard, when you're describing these symptoms. And unfortunately, as you said before, Dr. Najat, there aren't any tests that are fully available everywhere to diagnose and to even see the symptoms or this what could be endometriosis. And that's something that I went years without hearing at all. They didn't even say, oh, it could be endometriosis. It was just never even mentioned. And you learn in my journey, we've definitely learned to advocate for yourself. You do have to do your own research because it really is the freedom that we have as in using our voice and trying to figure out what is going on in your body and to be able to find answers from there. And that's how we also came to learn about endometriosis. We came to find Dr. Najat through also a search in specialists that specialize in treating and diagnosing endometriosis. So once we did find Dr. Najat and we did get the surgery done, it was significantly better. I would say it was a complete 180 turnaround from my suffering for so many years. I mean, it impacted my everyday life. It impacted my schooling. I had missed several days of school. I was working part-time in college. There was a lot of things that I could not enjoy as a young woman. I wasn't able to enjoy going out, family vacations. There was a lot of things that I could not do because of the pain. And they also, my mom can, share how much she suffered seeing me in pain and not being able to go out because of it, and how much it impacted my life. But finally being able to find Dr. Najat and getting the treatment, it was a freedom physically and emotionally, a freedom to be able to finally find the answer. And from there, we have managed now through long-term treatment, through contraceptives. We also, in other webinars, Dr. Najat had a panel of other holistic doctors notifying the importance of diet and exercise and how it impacts, as endometriosis is an inflammatory disease, and having an anti-inflammatory diet. So definitely combining modern medicine with holistic treatment is now what I'm focusing on as long-term. But I have been able to get my life back and being able to enjoy things that I couldn't enjoy before without pain. And definitely being able to encourage other girls to be able to find their voice in describing what they're feeling and advocating for themselves to do their own research and to find answers and to find medical professionals who are aware of endometriosis and who can help them.
Alexis, thank you very much for saying that. And what Alexis also refers about diets and alternative medicine, if you go to endomarch.org and on the top go to the webinars, then you can have the session on the diets and alternative medicine. There are many sessions, as I mentioned before, about different organs involved with endometriosis, bowel, bladder, ureter, diaphragm, other organs, also alternative medicine, infertility treatments, and other sessions. You can go over there. Well, now, Maria, when you hear the story of your daughter, please tell us, how did you navigate? How were you feeling when Alexis was going through all those heartaches, and tell us, how did you support her? How are you supporting her now? And tell us about your emotions, what you were going through.
Well, first of all, let me just say that I'm a crier, so forgive me if I get a little emotional and start crying. I will say that at the beginning, when she was younger and she would share and we would go to family vacations, she couldn't even walk because of the pain. At the beginning, it was a little annoying because I thought she, like someone mentioned, wanted attention or was exaggerating. But as she got older and it progressively got worse, then I started listening to her and how she described, the pain. And it was not just her, like you mentioned, it wasn't her reproductive organs, it was just her whole body. And it was excruciating trying to hear your daughter describe these pains. You take her to the ER, you take her to gynecologists, you ask them, what could this be? What is wrong? And nobody would give us an answer. And we just didn't know where else to turn. But I went to every single appointment with her. I was right next to her. I allowed her to express herself, because one of the things that I found out as I went with her that made it angering for me is that as a mom, when you go with your young daughter to these appointments, doctors look at you as if you're being overprotective or controlling, and that your child cannot express herself because you're present in the room. And so I tried to give her space and room to express herself so that the doctors would see that it was her that was crying out for help. But deep down inside, I was screaming for somebody to please help my daughter. So it's been very, very difficult for us. And still today, if she has a crisis, it's just devastating to see her in pain and to see her crying sometimes, and your hands are tied. There is nothing you could do. But I will say that after the surgery that you performed, she has gotten so much better. We're able to go out for walks, and it's so different. But it has been difficult as a family, as her mom, to see her suffering and not able to do anything, and especially not able to find anybody that could give us answers and that could help us.
Thank you very much. So during your course of treatment, and how have you managed, or when Alexis decides one method versus the other, how are you helping her in her decision making, or how do daughter and mother talk to each other and you decide?
Yeah, I think that we have emphasized just the whole health wellness, as far as the holistic treatment in the long term. I think as a family, when one of us does something, we support each other to the point where we also participate. So in research about the anti-inflammatory diet, of incorporating more anti-inflammatory foods or vitamins or supplements, they are supportive in also wanting to change their diet, just because that kind of diet and just the health, the wellness, just it doesn't encompass just endometriosis. It really could be good for a lot of people as far as your health is concerned, and incorporating diet. So they're supportive in me of also participating. And so when we do groceries, or we buy stuff, or we do different recipes, and we cook dinner together, in also joining me of what I can eat or what I can't eat, and supporting me in that. So it's been fun as a family, and being able to get healthy together, in incorporating that kind of treatment, more holistic treatment.
Yeah, in your daily life, you and your mom, in general, what advice would you give to a family member who has endometriosis in the daily actions, reactions, foods, emotions, and treatments. What advice do you have to them? How to, in general, how do they conduct their life?
As a mom, I will say be more proactive and advocate even more for your child, but be more proactive and getting informed, learning what is helpful, what is going to help with the different aches and pains and symptoms that they feel, because they're different. And some month it might be one part of the body, and then the other month it might be something else. And if you are educated on what is good, then you could help with that. Also listening to them and being understanding and sympathetic, because they're the ones that are experiencing the body and the pain in their body. We're just watching them suffer, and there's very little we could do. But when we're there by their side and find any way to be able to help alleviate the pain, listen to them, and just be understanding, to me that's the best thing that you could do as a parent.
Yeah. And as a patient, I would say just don't give up. Don't give up, because you feel like giving up and you feel like you're alone. I felt alone for years, and I honestly don't even remember meeting anyone that had endometriosis. We didn't even know what it was. So I didn't even know if we knew anyone in our family or friends that had endometriosis. So I felt alone for years. And even you describe it to other women. I had other women tell me, oh, we all have cramps. It's just cramps. We all have our period. And it's not that. My advice is to not give up hope, to not stop fighting. You're stronger than what you think you are. And there is always hope. And through a lot of prayer, we're a family that prays together. You keep the faith and you keep the hope in fighting for answers, fighting for yourself, and being strong for yourself and for the people around you. You have a purpose. I honestly believe everyone has a purpose to be here, and your story, your life can change someone else's life. So for me, suffering as a endo survivor, I could say don't give up hope, and definitely fight.
As a mother and daughter, what would you like to see happen? What is your advice for medical professionals? What do you think, ideally, what do you want to see? What advice do you give to the patients, and what advice do you to the medical professionals, to the doctors, and what do you want to see in general to happen?
We had talked about this a little bit before the meeting started, but we would want it to be a required topic of diagnosis in every specialty of medicine, all over the world. We would want it to be part of the curriculum. We would want it to be just known and taught to medical professionals in every specialty. And I honestly think I say every specialty because as doctors, as specialists, you might be seeing a patient that might have multiple symptoms. So a psychiatrist, for example, might be treating a patient for depression and anxiety, and it's a female, and she might be describing other symptoms that could be associated with endometriosis. So even a psychiatrist, if they were educated upon this illness, can then refer their patient who's being treated for depression or anxiety to see an endometriosis specialist or a gynecologist that specializes in endometriosis. I would want to see that in the medical professional field as required treatment and curriculum, to bring awareness, to be able to diagnose and treat endometriosis. But I would also want to take it a step further. I would honestly also want to see laws being in place in employment. And I think this is a little bit of work that you're also doing, Dr. Najat, and your team in employment to be able to bring aid and awareness to the illness, if it's a work-related disability, or being able to have accommodations for those who are suffering severe symptoms of endometriosis in the workplace. So in every spectrum, so from medical professionals to employment is what I would want to see. And I think we have made progress, but there is still progress to be made. And I think, like I said before, it's not giving up hope and to continue fighting is what's important in my advice. And to do what you can, either in sharing your story to anyone and bringing awareness, even in your circle of friends and family. It starts somewhere.
I would like to see a way for girls to be diagnosed, because honestly, she's been suffering since she was 10 years old.
Yeah.
So if there is a method of diagnosing it early, and I also would like to see other treatments, because right now there is a certain amount of treatments that they could receive, but I would like to for a treatment that is specifically for each female that is going through this, because each one of them is different. And I just want to share one more thing, that the one thing that has stayed in my mind since you diagnosed her was how she broke down when you told her, and it wasn't in her head, that she wasn't crazy. And I'm so thankful for that. And I still break down and cry, because for years she thought she was crazy. And she thought she was a burden to her family. And so finally, thank you, because of your diagnosis and your surgery, and just everything that you've done for us as a family to help us go through this.
Thank you very much, Maria. It is really a privilege to be able to have helped Alexis, and you are very kind, and thank you very much for your advocacy. And as you say, we cannot go and operate on everybody. So, and we don't want others like Alexis to go through 10 years of going doctor to doctor simply because there is not enough awareness about endometriosis. And I appreciate you being part of this program to raise the awareness. At the same time, as you know, by yard is hard, by inch is a cinch. We have an app. It is called Najat Endometriosis Advisor. You can download it. It is completely free. And that would at least could give you a guideline if you have endometriosis that could help you to go to a doctor. And I appreciate all of your comments. So I'd like to turn the situation to Lily and her family. Thank you again, Alexis and Maria, and please don't leave. We are going to come back and forth to you. You know, and Lily and Karen and Ed, they have also their story. And why don't we start, Lily, you tell us how your situation started, and Karen and Ed, tell us how you supported your daughter, and tell your story and your recommendation, and you know, how the do's and don'ts about patients with endometriosis.
Hi everyone, my name is Lily. I think that the hardest thing is that my story is so similar to Alexis's, in that it's honestly similar to everyone who is going through endo, that for years we're told it's in our heads and we're led to believe we're crazy, and that the pain we're feeling and the symptoms we're feeling are not real. And we're seeing trusted professionals, and because they're professionals, we just inherently trust them. But we shouldn't, because we know our body's the best. And the hardest part for me was that the entire time I was told it was in my head, I knew it wasn't. I knew my pain was real. I knew my symptoms were real. I was missing months of school. I couldn't go out. I was bedbound for almost 2 years. I knew this was real, and I was told by tons of doctors that it was in my head. So this started when I was 14, and I'm now about to turn 20. And I was so lucky and grateful to find Dr. Najat at the age of 18. He was the first doctor who ever listened to me and told me that my pain was real and that it wasn't in my head. He performed my surgery, and I was diagnosed with stage 4 endo and adenomyosis. And from there, he gave me a voice and gave me the power to use my voice. And I found out I have like 15 other diseases that all like coincide with endometriosis. And from that day, I've never like stopped using my voice. Every doctor I've seen, if they told me it's in my head, I immediately stopped seeing them and switched to another doctor, because I know my body and I know that this is real. So since meeting Dr. Najat and having that surgery, my life was changed. And I've again been diagnosed with about 15 other diseases, and I've been given my power back and a voice. And I still live in chronic pain every day and debilitating symptoms, but I feel like I have a life, and a life that I want to live. And my parents have really helped me along the way, and I wouldn't be here without them.
Incidentally, I like to everybody to know and congratulate the brilliant Lily that in her going to college in excellent, wonderful school in Boston, and we congratulate her. And also we congratulate her parents for having a wonderful child, raising a wonderful child, that she is very advocate, and you can see her continuously advocating for other adolescents with endometriosis and their issues. So Karen and Ed, why don't you say, how are you navigating, how are you dealing with Lily's, obviously the parents, like Maria loving Alexis and going through much emotion. I have seen you and I have seen Ed, how you guys are so involved. Tell us how you are navigating the waters and your advice, your recommendation for endometriosis. You have the podium to talk about the supporting. I'd like you to address any issue that you think it is important. The caretakers for the parents of the adolescent, they should know, or that they are worried about the future potential fertility for their children, because it's all on the minds of the parents with the young adolescent patient with endometriosis.
Sure. I mean, so it's just amazing to hear like everyone's stories and how similar they are, that your daughter is kind of going through this constant seeing professionals who are kind of denying her experience and her reality, and that you're basically convincing people that what she is saying is true and real. And you know, Karen has been just so incredibly supportive of Lily and kind of going through all these things, like they were saying, you know, you just have to kind of sit there while you, not only is your daughter not believed, but they pathologize you because, you know, it must be you who's causing the problem and who's not being kind of supportive of what's going on. And I think it's just so important to kind of believe what is being said, and supporting them and getting whatever support and care that's necessary to make them feel better. Yeah, it's been a very challenging road, as others have shared.
Yeah, I could very much relate to the first family's discussion, the mom, and I think there's such a power differential between physicians and patients, and there's so many cultural and gender and personal reasons why it could be very hard to push back in a physician's office. And I think we were hopeful in the beginning that, you know, we could go in and say, this is what's happening, and that they would have an answer. And it was really surprising, not only that people didn't have answers, but they were very dismissive of these symptoms and minimizing the symptoms, and then going right to anxiety, right? Like the first story. And I remember a primary care physician saying, oh, she has IBS. And I remember saying to her, isn't that kind of what's diagnosed after everything else is ruled out? Like, wouldn't we kind of look for other things? And just everyone kind of looking at a symptom instead of looking at somebody as a whole and seeing how all of these different symptoms connect. And, I'm very sorry for the first family, what, you've been through, the pain and the suffering and the despair. We can relate to that. I think what I've learned from this experience is that going into doctors' offices prepared with as much information as possible, writing down the questions ahead of time, because that power differential can make you kind of lose your voice. And when someone is sharp with you or dismissive of you, it can silence you very quickly. So I think writing down what you want to say, literally having the paper in front of you, and then having prepared what your next sentence is going to be if they say something dismissive or insulting is really important, and actually kind of to practice that ahead of time. So if they say the tests are normal, there's nothing wrong, that you've practiced saying, well, these particular tests are normal, so these particular conditions are not what Lily has. So what would be our next step? Who would you refer us to, or who can consult to you to know what the next set of exploration steps are going to be? And following it up with a paper trail, I found was vital to summarize the appointments in those emails with your concerns that haven't been addressed, with the requests for next steps. I think having a paper trail is a good nudge for physicians to know that there's accountability and that you're documenting that you haven't gotten answers and that you're requesting next steps be taken. And again, it's intimidating, and I think there's always a fear that if you push too hard, you're going to be seen as difficult, and then you're going to be completely dismissed and avoided. And, people did say, not only did Lily have anxiety, but I must have anxiety. I definitely related to the first mom with them thinking that you're the reason that your daughter is experiencing pain. I actually had a pediatric cardiologist suggest that maybe I had Munchausen by proxy, because he saw in the chart how many doctors we've been to. And that was terrifying, because I knew that meant if that was put in the chart, CPS could get involved. No doctor would believe us. So it was kind of always living on the edge of like pushing, but having the fear you're going to push too hard and that your daughter is going to pay the price of that. I think seeing your child in pain puts your body into like fight and flight mode, because you're kind of in this mode of feeling like your child's in danger, your child's in pain, you have to do something. And then those stretches of time between appointments or between new ideas, you're still in that fight or flight mode. And so it's very taxing and exhausting. And I think it's just really important for, as the first family said, that you might be in that place listening to these stories where you haven't gotten answers, you haven't gotten support. And it feels like there will never be answers and never be support. And I would just implore everybody to know that eventually you will find the right person. Eventually you will have the right answers. It takes much longer than it should. And there's a lot of bad experiences along the way, but you will eventually get that answer. I think something that's been incredibly important, as Ed said, was to listen to your child. As the first family said, believe them. Adjust your parenting, because there might be a moment where Lily needs hugs and cuddles, and the next moment she might just need to be completely left alone because it's so overwhelming to be in pain that you can't talk, and not to take it personally, but just to be like available to adjust at every moment what their needs are, and to be careful not to make them feel badly, like if you assume that your plans could be canceled, because if you're like hoping so much that you're going to do something for them or with them or that they're going to do and they cancel, you have to just have expected that ahead of time, that it's likely plans will change or not happen the way that they're supposed to. And I think the last thing is like really get connected to the online communities, because you're going to learn so much from them. We learned that endometriosis isn't often alone as a disease, but there's a constellation of disorders that often show up with endometriosis: Ehlers-Danlos, mast cell activation, postural orthostatic tachycardia syndrome. You know, there's a lot of things that can show up with it. And we discovered that from the online community sharing their stories. So get connected to information that way as well. And also just find ways to replenish yourself so that you can hold the hope when your child can't. Like, you really have to hold that hope for them when they're hopeless, and giving them those mantras: we're going to figure this out. We're not going to give up. We're with you all every step of the way. And getting replenished yourself so that you can hold that hope. Sometimes the communities that we thought we have disappear, and sometimes we need to find new communities of people, even if they're just online, to feel like we're not alone, because being alone is what I think causes the despair. And it's a family disease, as so many diseases are. They're family diseases. They affect everyone. So talking as a family, looking at the impact on your marriage, on your other children. You know, Lily has a big sister. What is it like for her, giving her a voice? Because sometimes she would be not as given as much attention at times, and having those honest conversations with her. What is that like to have a sister with chronic illnesses, and how can we support you in this, you know, seeing your sister in pain? So just having a lot of conversations and holding hope.
Yeah, and I'm emotional too. I really wanted to emphasize what Alexis said, that to never give up, because I've had, since I've been struggling since 14, there have been a lot of times where I felt so alone and I thought nothing would ever get better. And I wanted to give up so many times. And I'm so glad that I didn't, and that I'm holding on, and that I've been given answers, and I'm still searching, and I probably will for the rest of my life, but things get better. And I truly live by the fact that things come in waves, because maybe for 1 week I have a ginormous flare. Like the past month has been incredibly hard. I've been bedbound for the past month, but then this past week it's come around, and I'm feeling better, you know? So it really comes in waves of, you know, it can be really awful and it can get better and go back down to bad, but to really hold on, because if you give up, you won't be able to experience those ups and those good things in life. And that truly finding the community online has been the biggest blessing for me. I found so many other people with endometriosis and all the comorbidities that I have, and I just feel like I'm not alone, that I have a community, and that I'm not going through this alone, that other people are experiencing this, and that I have support and people to talk to. And I just think that's so important. And I just have this quote I wanted to share that kind of inspired me to join and have this internship with EndoMarch and share my story and use my voice. It says, "Scream so that one day, 100 years from now, another sister will not have to dry her tears wondering where in history she lost her voice," by Jasmine Kaur. And I think that's so important and really resonates with me. And yeah, thank you guys.
Well, I like to thank you very much, the Lily, Karen, and Ed. You have been very kind to share your story. And you have been a great parent, obviously, like Maria was to her daughter, and Jean and Diana to their daughter. And prime example, she has a wonderful future. She is going to Boston, and she is going to be under the care of wonderful physician, Dr. Louise King in Harvard, was one of our former fellows. So what it is you say is, physicians, all of them are going to medicine to help their patient. Doctors are altruistic. They want to help their physicians, and they mean very well. They have good intentions. And the issue, unfortunately, sometimes it is unaware, because there is not awareness about endometriosis. And what mind doesn't know, eyes don't see. And I often tell my fellows, who are very brilliant gynecologists, are going to the best medical schools in the United States, And when they come in my operating room, often they only recognize very, very obvious endometriosis. They don't recognize many variations of endometriosis. And what mind doesn't know, eyes don't see. And because these physicians who come here, and they come from excellent programs, and when I ask them, well, do you see anything? And they say, no, that means their teachers don't know. So it is, again, those physicians, they mean well, they want to help, but because there is not enough awareness, that's what we are trying to change, to teach. That is why, as I have said, by yard is hard, by inch is a cinch. Gradually, we are moving the mountains. We have schools and fellowships for endometriosis, and we are advocating in American Society of Reproductive Medicine and Society of Reproductive Surgeons. They have dedicated, again, significant resources because of that interest. And right now, the president is Hugh Taylor, and Sean Tipton is the director of the advocacy, and they are very much involved to involve fellowships. There is going to be a Dicherney Najat Fellowship or a group more related to endometriosis, and American Society of Reproductive Medicine and Society of Reproductive Surgeons. They are going to give more awards to increase awareness about endometriosis. So all the physicians, they want to help, but we just need to do more education and let the scientists and physicians give them the resources and the power to do what they are good at, to find resources. The Worldwide EndoMarch and the Najat Family Foundation, they have been honored and privileged because of the support of families like you to advocate and give grants to wonderful schools with excellent research capabilities like Northwestern, like Yale, like Harvard, and Dr. Hugh Taylor in Harvard, in Yale, and also at the University of North Carolina in Emory Medical School, Medical College of Georgia, and UCSF, Stanford, that they do more research to we make changes, we make progress. And I thank you really for sharing you and really I'm looking forward for you to keep working. You become an endometriosis specialist, and we are going to support you, and you are people like you, we are going to change the world for the patient with endometriosis better. And example of it is in the next family, Jean and Deanna Taylor, that their daughter was one of our patients and is our patient, and now she is on her way to become a physician and help patients with endometriosis. And I let Jean and Dina to tell their stories and their support. Taylor is on call today, so she couldn't join, but I let her family take the podium.
Okay, well, I just want to thank Alexis and Lily for being so strong, because this is a very difficult subject to talk about. Even for Taylor in the medical field, I think this has even fueled her passion even more to help others, but it is very difficult for her to talk about because it does affect, in their mind and my mind, their dating life. Am I ever going to have a baby? When you start out young, like they have, and Taylor started out at 16, will I be able to ever have a baby? Will that affect my dating life? Is anybody going to want to date me? So it really is very heavy battle that we went through and that she has. And I'm very sorry she couldn't be here. She would love to be here to speak on about it as well. But you can go ahead and say something.
Yeah, so I mean, it's we understand what all you girls are going through, obviously, with Taylor now being 29 years old, positioned to graduate medical school in 3 weeks. We're very excited. I know that her experiences with Dr. Nazat really helped, I think helped her mentally, emotionally, and really encouraged. She had the design and desire to be a doctor prior, but I'm sure the experiences really helped solidify that and keep her going through the process. Taylor started this journey at 17, and it kind of came on really fast, kind of hit everybody immediately. Thank goodness we were able to get her to Stanford, get her to Dr. Nazat, or else her life would not be the same today. She wouldn't be in a position where she could have children in the future.
If we would have listened to the other doctors, and there was 3 other ones that were sending us from doctor to doctor to doctor, and we weren't, really saying, hey, no, this isn't going to happen. We're going to keep on trying to fight. And if we weren't being our own advocate and trying to help her and listening to her and her needs and her pains and what she was going through as well. So, yeah.
It's been really important. I mean, in our case, in the last 10 years of Taylor's being under Dr. Nazat's treatment, she's gone through 3 surgeries in 10 years as the disease, the endometriosis progresses, I guess, in her body. But every time that she goes in, she has massive results as far as the way she feels, the way her body operates, everything. There's huge differences every time. So, whether we don't know enough about it, whether this is something that she deals with, at least she knows how to deal with it. She knows how her body feels. She knows how to adjust and control her diet and her exercise and things like that to make herself feel better when she's going through it or dealing with it. And so, we're just blessed to have been able to have her under Dr. Nazat's care for the last 10 years, because we don't know what her life would be or what our lives would be without it, had we not, found him and been able to alleviate the problems that she's had.
Yeah.
Well, we congratulate you, Jean and Diana. You have been a wonderful, wonderful parents, and that is how I like you to share your story and tell. You have as much as time you want, because there are so many people watching already. Know Zoe has told me there are so many people are clicking and they want. So we will continue until all of you have said what you want to say. Don't worry about the time limit, because people are a lot want to see what you have done. How did and again, I congratulate you, because Tyler now is a very brilliant, going to be a physician. She's in medical school, graduating, as you said, 3 years. And I have known her since she was a teenager. And I admire her, how she dealt with everything when I saw her. And because you said the story and you said it yourself, so I repeated that she had already lost half of her tube and ovary, and tube and ovary in one side. You said it, and she's only at that time was 19. So it is, endometriosis is a very perplexing disease. It is a difficult disease. That is why we want to empower the scientists, the researchers, the government, to help those entities. We need to help these patients, because when we help one, the whole foundation of the family is helped. So I congratulate you. Tell us more. How did you navigate during these years, and how did you encourage her? And I know every time she said, I told her you should go, and I am encouraging her now to become a surgeon. for endometriosis, and I'm not giving up. And I know she is very much interested. She is working on it. But tell us, how did you manage to encourage her to stay and keep going? And how hard was on you as a couple to see your daughter going through that?
You have to know, well, obviously there's a lot of, a young lady goes through a lot of emotions, and, sometimes those emotions can be more challenging than others to deal with. So, sometimes it was my turn, sometimes it was Deanna's turn to take care of it or handle it, or she would bounce back and forth between us, which it was nice that there was both of us here to do it. I don't think either one of us would have been really good at doing it on our own. So,
well, it was a lot to navigate because and they were talking about going on vacation. Well, we had planned for Taylor, it was a little different because really didn't have any issues until one day she had issues and she just dropped to the ground. And then I had called up the head of a hospital that I know very well. He said, listen, what I want you to do is give her Vicodin for pain. Call me if she starts to vomit. Within an hour, she did start to vomit. I brought her into the ER. He had referred me to one that he had said a doctor that was highly recommended in our area for that type of thing. They left her in the hospital for 7 days. Then she started getting feverish, gangrene set into one of her tube and ovary, and they had to take that out because the endometriosis was just taking over in her body, taking over that tube and ovary, from my understanding. But then, then they wanted to take out the other one, and we just kept on fighting and fighting. So we went through months, and we went through a vacation that we had planned in Italy for 25 days. And that was very difficult because at every turn she was sick and she was not able to, very emotional. It was just, she wasn't able to join on a lot of things that we had planned. And so we had to, one or the other had to stay back with her. And so that was very emotional for her as well to go through all that. And then,
well, I was going to say, like to kind of repeat what Lily was saying earlier, it's really hard on a young person to have these issues and nobody really understand them, because obviously as parents, we don't really understand what she's going through or feel what she's going through. So it's hard. I mean, we believe her and we support her, but you don't really understand it or know why. And it's hard to go through that. So to try to, as a parent, you don't really know how to deal with it. And so we just try to be encouraging and emotionally supportive and, get help where we could. But that's really, it's a challenging situation because you just don't necessarily know how to deal with it. It's not anything that, we've experienced in our lives. So it's very difficult. And we're kind of, this whole march is a blessing because it's going to give, like Lily said, a lot of people a voice to understand maybe what may be happening within them. And that's going to allow not only the children, or the patient, but also the parents, like us to understand and get support and figure out ways to help.
I wish we would have known about this 15 years or 14 years ago when she started going through all this, and we would have been able, we just had no knowledge, and we were going off of what all the doctors were telling us. And her tube and ovary had a very big cyst on it, so we just thought, well, that's what it has to be. It would be nothing else but this cyst. But when we brought her to you and you performed a 7-hour surgery on her, the miracle. I mean, she was in the doctor's office prior to that, the one who referred me to you, rocking, crying hysterically, just so emotional. And she felt so amazing after that surgery. It was a blessing for her. And then 2 others, and then as she progressed again, and then it took out her appendix and wrapped her colon and did all that, then you did perform more surgeries. But she seems to be doing very well now. She's 29 years old and seems to be doing very well. And she's very positive about her outlook on having children as well. So that's a good thing.
I congratulate you, Jean and Diana, as a parent for what you have done with your daughter, and she has a wonderful future. And thank you for sharing your story and her story. And you want to see that is what we are talking about, the enigma of endometriosis, that it doesn't differentiate between age, race, the social status, anything. She was a very young woman, and because you shared her story, that not necessarily, when a young woman has endometriosis involving multiple organs, bowel, bladder, ureter, and a very young age, it is that these are the mysteries of this disease that we have to solve, and to teach it more, to raise more awareness. And it's couples like you that, and of course the Lily's parents and Alexis' mom, that you are the heroes and getting the story out and encouraging, participating to help other patients. What other advice would you give to couples who their daughter has problems? What is your recommendation? Any other recommendations you have? And I would ask these questions after you from Lily, the parents, and also Alexis' mom.
Well, now, I mean, the first thing I would say is download the app. The app is going to be a wonderful tool that is now available to people that wasn't, for all of us, to get involved with EndoMarch and to, research it, because there's a lot of information available about it that wasn't available just a few years ago. So that's huge. And I would recommend that anybody that thinks that their child is having an issue, to definitely use those tools and get that information, because that's going to would have made it easier for us. And I'm sure will make it easier for those in the future.
And get her with the right doctor that believes her as well and that is willing to listen to her. And like Alexis said, the same thing is the holistic side of approach of what you eat and what you intake into your body as well. And we did look at that when she was younger, but that wasn't enough. Obviously, she needed all the surgeries as well, but that really helped her after once she had the surgery.
Thank you very much again, both of you. And I truly appreciate your participation. And I look forward to celebrating many occasions in relation to your daughter, Tyler. Now, I would go and ask the same question from Alexis and her mom, Maria. And what are your closing comments? What recommendations do you have? What do you recommend the families should do in relationship to their daughter?
My recommendation is, parent, if you want a knowledgeable, experienced doctor in endometriosis, go to Dr. Nezjad's website, because your website is packed with all the resources, information, everything needed. We say that we were blessed to have come to LA, and it was Alexis doing her research, and then she gave me your website so that I could do my own reading and research, and we compared it to other so-called specialists in endometriosis, and yours was the best website with all the information that we needed, and that's why we decided to go see you. Even if we had to drive 6 hours, and like we've told you before, if we lived in the East Coast like we used to, and we would have to come see you every year or every 2 years so that you would treat her and you alone, we would do that for our
Yeah.
daughter. And my advice is, if you want the right information from an experienced and knowledgeable endometriosis specialist, seek Dr. Nesjat.
Yeah.
That's what I would advise every single parent in the world.
Yeah. And I would echo that by saying it is worth the sacrifice of your time, of putting forth, sacrificing time to do the research, and sacrificing time or even finances to be able to seek out a specialist. And I think, echoing what my mom said, it is worth, even if it's more expensive, if it's further away, of finding the right doctor, because you don't want to waste your time and your money on going to maybe a closer doctor that can't help you. And the three families, we spent years, and we spent probably thousands of dollars going to doctors that told us the same thing. They didn't know what was going on. The tests looked normal, and they referred us to doctor after doctor. So sacrificing your time and research, and even if it needs to go that far as traveling to see an endometriosis specialist and to get the help that you need, it's worth it. And to not give up the hope in searching for the answers and for the right specialist to treat you, because that freedom physically and emotionally in dealing with this illness is worth it. You should not have to be complacent and comfortable with suffering. Families shouldn't give up hope and feeling helpless that they can't be there for us. You have to fight, and it is worth the sacrifice. And I just want to thank my mom and all of the parents here supporting, because like Taylor said, we wouldn't be here without you guys. And my dad is in the other room, but he has also been a huge, and my older sister as well, has been a huge help in supporting me throughout these years, physically and emotionally. Their sacrifice has made where we are now possible. So I just want to thank you, and for any parent or family out there watching, I want to encourage you in your journey that you are vital to us. You're the real MVP. We need you guys, and we appreciate and are thankful.
Thank you very much, Maria and Alexis. It is a pleasure and privilege to have had you, and thank you for your kind words, and also thank you for encouraging others, and also for your efforts to raise awareness and help all the patients with endometriosis around the world. And again, you have been wonderful to be part of the program, and please give the best wishes to your mom, your father, and your sister as well. And I turn the table now to Lily and her family, Ed and Karen, and see what is their last words and what are their recommendations. And go ahead, please.
I agree with what has been said before our turn. I agree with everything. In addition, I think a recommendation for families to support their loved one is that I think the measurements get changed in people's lives when they're dealing with a chronic, painful, debilitating illness. And I think it's shifting, and what might seem like a very small thing, getting out of bed or taking a shower, or sometimes like doing laundry for Lily was like a big deal that day, and really seeing that as an accomplishment and cheerleading that and acknowledging that is really, really important. I think that wanting your loved one to know that their perseverance is challenging. I think it's really hard to always say to someone, you're so strong, because what you're really saying is, you have no choice but to be strong. And it would be nice for people not to have to be strong and persevere through pain and suffering every day. So it's a strength, but it's also a curse. All of these people today and who are watching, who are struggling, like, you have to be strong to get through this, but it's not, you've been given no other choice. And so letting people have a bad day and have those softer moments where they're not feeling as strong is really important too, and supporting them kind of getting back up when they're ready to get back up, and giving them the message that it's okay to be down, It doesn't mean it's going to be forever. And just kind of sometimes being in that down space and just letting them be there. Sometimes we want to cheerlead, but sometimes like there's grief involved in having a chronic illness. There's grief and suffering and sadness and loss that we want to acknowledge as well. But through all these changes of kind of losing what you thought was your path, or having that path be temporarily put on hold, can be really demoralizing. But knowing that the path then changes, and that path can be a really fulfilling path, like, you know, getting to talk today and knowing that we might help one other family is incredible. And, you know, hearing the story of your daughter going to medical school and maybe being an endometriosis surgeon, which was something probably different than what her plans were originally, you know, just having that spirituality of the first family and being together and having those beliefs and those practices really giving them strength, you know, all the different ways that our paths shift and change, just letting it happen as opposed to fighting it and trying to hold on to what you thought was going to be your life, I think is can lead to that despair. But letting go of those paths and knowing that you still have a enriching, powerful, beautiful life ahead of you. It's just maybe not what you thought it was going to be, but there are blessings along this path and an expansion of who you were. It's not just loss, it's gain. You know, I think all of these daughters that have experiences that we're talking about and are speaking for themselves today have gained so much wisdom and insight and understanding and empathy and compassion. And, you know, these are things that make you even more beautiful than you were before the endometriosis caused so much challenge. So just really seeing the light as well as the darkness, but accepting the darkness as well is really important for family members. I also just want to say that there might be people watching who don't have family support or are alone in this, or their families believe it is anxiety or believe the doctor's messages. And I just want you to all know that you can make your own families, that, you know, we've been very lucky to have support within our families as we're hearing the other families, but sometimes people are on this journey by themselves, which I can't imagine. And so finding people that become your family, whether it's the online communities or other ways, is really important, because the support can come from anywhere. If you're not getting it where you would hope you would get it, you can find that elsewhere too. You're not going to be alone.
I think
Thank you. I'm so go. No, Miss Lily, please go ahead. I'm sorry.
I just want to echo what Karen said, that, you know, not everyone has a support system or a family who's supporting them, and that genuinely finding a community online through social media, even if it sounds silly, has been life-changing. As someone who does have a family, just having that community online is so helpful. And to anyone watching, if you think you have endo or don't know, or, you know, there's a community, and I'm also there. Like, I would love to talk to anyone who needs some support. Just like message me. Like, I'm sure any of us would be so happy to talk to you. It really just fulfills my heart and makes me so happy to know that I can help at least one person who might be going through something. It's truly given me a purpose in my life when I felt so lost and felt like I had no meaning. My illnesses have genuinely given me a path and a purpose where I never expected it.
Yeah, so support and education are just so important. I mean, this disease is so odd. It's normal cells growing in the wrong place in the body. Like, how could that cause a problem? You know, I think for me, like, one of the most, I don't know, impactful things was seeing the pictures, right? Like, you can't see it from the outside on the person, but when the surgery was done and you saw the pictures and you saw the endometrial cells everywhere where they're not supposed to be, it's kind of that just seeing and understanding what is really happening and what people are going through. It's like, that's why I think a lot of doctors don't know. They can't, like Dr. Najat said, they can't see it. You know, there's no way to image it. There's no way to diagnose it other than kind of going in there and looking for it, which is just a horrible way to have to find out that something this serious is going on. And I think it's very important for the people who have gone through this to educate people that they've kind of interacted with the other doctors. I think, you know, Lily was, when after she had her surgery and kind of had the images and wanted to go and tell every other doctor and say, look, I really had something wrong with me. And here's the evidence. You know, if you want evidence, here it is. Look at it. This is what I was going through. And it's important to educate people about this disease and figure out a way to diagnose it without having to go to surgery.
Thank you so much. Again, the three couple, the three families that we are our guests today. It has been a true pleasure and privilege to have you. We have had a lot of the questions and texts that how about endometriosis and infertility or organ dysfunction. We did not forget about that. We are doing it session by session. This session was essentially for the families who have gone through the support of pain. We have another session for infertility couples that actually have no symptoms at all. The couple have no symptom. The semen analysis of the husband is completely normal. All the tests are normal. And the couple are told over and over that everything is okay. We just don't know why you are not getting pregnant. They have had IVF. They didn't get pregnant. The majority of those patients have, in our research, which has been published and documented, have endometriosis. But in medicine, things go very slowly and progress very slowly. Many, many things that we advocated or developed 30, 40 years ago, almost 40 years ago, now gradually are becoming commonplace in medicine. In medicine, very rightfully, especially surgery, very rightfully, everything has to be tested and retested and tested to make sure we do the right thing for the patient. And because these are, especially surgery, has to be learned, so it takes a long time. But the hope is coming. We are making progress, and a lot of progress has been made. We are making, I do see it in my own students, how they are excited. Look how Tyler is in medicine. Right now, Lily is on that direction. And Alexis is working towards that goal. So a lot of things are happening. We are going to address the couples and issues of the infertility and also organ dysfunction in another session. And also we are going to have another session exclusively more about adolescent endometriosis or other misunderstandings and myths about endometriosis. These are sessions that are coming. Please look at the program. And if other issues you are interested, many of your questions that I didn't get to answer here because all three families were so interesting and had so much good to say. We will answer some of those questions privately for you. And we thank you very, very much. Go to the website of the EndoMarch. There is a free download of the app. This is for you. We thank all of you around the world for your support to help each other, to help yourself and future generation of the patients with endometriosis. This is yours and you have to support it. We are doing our best. And those of you who are able to donate or support, again, that is great. Get involved as much as you can. Everything is very open. Congratulations. Hang in there. Forward we go. I'm looking forward to seeing you next month. Thank you very, very much again, all of you. Bye-bye.
Thank you.
Techniques for safe and efficient laparoscopic entry. Center for Special, Minimally Invasive, and Robotic Surgery. In laparoscopy, placement of the initial port is often considered the most challenging and potentially injurious aspect of laparoscopy. With over 50% of laparoscopic injuries to the bowel and major vessels actually occurring during this initial step. Many studies have evaluated the safety of initial entry methods via the closed versus open approach, with the most recent Cochrane review demonstrating no difference in prevention of major vascular or visceral complications. Open entry is often called the Hassan method. Closed methods are more frequently utilized by the gynecologist. In this video, we will demonstrate multiple methods of closed entry for laparoscopy. No matter the entry method for laparoscopy, the patient must be anesthetized, with muscles fully relaxed, completely flat, and without tilt. Entering laparoscopically using the Verries needle is the most common entry method among gynecologic surgeons. We place 2 penetrating towel clamps on either side of the umbilicus. This is done to provide traction for safe Verries entry. Marcaine is injected infraumbilically. A 15-blade scalpel is then used to make a 10mm incision in the infraumbilical fold. The surgeon holds the needle like a dart. We attach the gas on high flow to the needle. The Verries needle is introduced at a 90-degree angle. Confirmation of intra-abdominal placement is suggested after feeling and hearing 2 pops, first through the rectus fascia and then through the peritoneum. Correct placement is also confirmed with the initial CO2 insufflation pressure reading of less than 10 millimeters. The Verries is held still until the insufflation pressure reaches 15 millimeters mercury. The Verries is then removed and the trocar is introduced using the towel clamps for traction. Intra-abdominal placement is again confirmed by opening up the gas valve to hear air escape from the port's insufflation site. Finally, correct placement is confirmed on laparoscopic visualization. Now we will demonstrate entry with the video visualization entry method in the left upper quadrant. The left upper quadrant, or Palmer's point, is a site used to enter laparoscopically instead of the umbilicus in cases of extreme obesity, extreme thinness, or to avoid pathology that is expected to lie just below the umbilicus, such as adhesions, hernia, or in this case, a gravid uterus. Our patient is in the 2nd trimester of her pregnancy. To avoid the gravid uterus, the left upper quadrant entry is selected. It is imperative that the gastric contents be emptied via OG or NG tube. We place 2 towel clamps 3 centimeters below the left subcostal border in the mid-clavicular line. A 5mm incision is made and the abdominal wall is elevated. The OptiView can be used either by direct trocar entry or, as in this case, after insufflation with the Verries needle. The Verries needle is guided in through the fascia and the peritoneum. In this case, before initiating the CO2 gas, we perform the saline drop test to confirm intra-abdominal placement. Then the gas is attached, low initial pressure below 10 millimeters mercury is noted, and the abdomen is insufflated to 15 millimeters mercury. The 5mm white-balanced laparoscopic camera is placed into the OptiView trocar, and the camera trocar complex is introduced into the incision with gentle rotational force and traction. On careful inspection, individual layers can be visualized at the time of entry. Subcutaneous fat is yellow, fascia white, rectus muscle red, inner layer of the fascia white, and peritoneum is shiny and bright or translucent. The obturator is then removed, safe intra-abdominal placement is reconfirmed with the laparoscope, and the CO2 insufflation is attached. Now we demonstrate the direct trocar entry method, which can be the fastest of the laparoscopic entry methods. Surgeons may select this method for its lower rate of certain rare complications associated with the Verries entry, such as gas embolism. A 10mm skin incision is made. We place 2 towel clamps flanking the umbilicus to lift the abdomen. The 10mm bladed trocar is then inserted through the fascia and into the abdomen. Intra-abdominal placement is confirmed with the laparoscope, ensuring no trauma to the underlying structures. The insufflation tubing is then connected. Last but not least, we demonstrate a closed entry technique with the LapCap 2, a novel pneumoperitoneum creation assist device that is used in conjunction with the Verries needle and can decrease the number of attempts needed to achieve intra-abdominal insufflation. This is an important point given the risk of injury to major vessels and to the bowel has been shown to be increased if several attempts are needed to obtain intra-abdominal insufflation. The LapCap 2 consists of a plastic clear dome with a central pass-through port of entry and is designed to elevate the abdominal wall, thereby creating space between the site of entry and the major vessels. The lap cap 2 is placed on the anterior abdomen with the pass-through port over the umbilicus. Sterile suction tubing is connected to the lap cap 2 vacuum line port, and the standard vacuum wall suction device is activated. Negative pressure is created, elevating the full thickness of the abdominal wall into the dome. The Veres needle is introduced through the lap cap 2 port of entry, through the umbilicus, with the CO2 gas on high flow. Features of reassuring intra-abdominal placement include low CO2 insufflation pressure and haptic feedback at the time of insertion. With the lap cap 2 still applied to suction, the Veres needle is held still until insufflation pressure reaches 15 millimeters mercury. The suction tubing is then removed and the abdomen allowed to return to its anatomic position. This results in a decrease in the read on the intra-abdominal insufflation pressure to about half. The lap cap 2 Veres complex remains in place until the insufflation pressure again reaches 15 millimeters mercury. The entire lap cap 2 Veres complex is then removed. Now the umbilical skin incision is made, and the 10 millimeter trocar is introduced. The lap cap 2 is a novel device that is simple to use and helps to increase the distance from the Veres entrance site and the great vessels. Use of the lap cap 2 with the Veres needle has the potential of decreasing the number of attempts needed to achieve intra-abdominal insufflation. The lap cap 2 can be added to the surgeon's armamentarium as a device that can be used to assist in safe laparoscopic entry and can be employed to help teach insufflation technique. It is our hope that this video will help the gynecologic surgeon refresh his or her understanding of the direct entry methods, and that he or she may take away some nuanced suggestions on efficacy and safe technique. The most important thing is for the surgeon and assistant to be comfortable with the technique he or she is using, and ideally to be adept at various entry techniques. The surgeon may choose, for example, to employ primarily the Veres entry, but in cases of subumbilical pathology, he or she may use the upper left quadrant with or without Octaview. Direct entry is highly efficient. And finally, the lap cap 2 may be especially useful as an enabling device when teaching medical students, residents, and fellows the important and otherwise potentially dangerous approach to laparoscopic entry.
Hello to all of our viewers around the world. Welcome. I am Dr. Cameron Nejat, the founder of Worldwide EndoMarch. I welcome you to our next series of educational teachings of Worldwide EndoMarch and Endo Explained. We thank all of you for your participation and for your interest in endometriosis. Every one of you around the world who has endometriosis, one of her members of her family has endometriosis, or has an interest in endometriosis, has been instrumental in raising awareness about endometriosis towards our goal to find a treatment for endometriosis and end the dynasty of endometriosis and its holding over the patient with endometriosis everywhere in the world. We thank you. Because of your participation, there are many sessions of teachings about diet, about endometriosis and infertility, about endometriosis and pain, back pain, leg pain, bowel, bladder, ureter, diaphragm, liver, etc., that you can go to endomarch.org and look at the webinars and find sessions about endometriosis of your interest. Also, Worldwide EndoMarch and EndoMarch is proud to let you know we have developed an app called Nejat Endometriosis Advisor, that it is free and it is donated to all the patients who may have endometriosis around the world. If you go to endomarch.org and look at Nejat Endometriosis Advisor, can help you to find out if you have endometriosis, if you have pain, or if you are trying to get pregnant, you are not getting pregnant. You can look at an app which could help you and direct you to see the proper physician. Also, we'd like to thank you for your interest of letting us know what you like to hear, and we are putting these sessions for you. The session today is about endometriosis and ovaries, chocolate cyst, endometriosis cyst, or endometriosis hemorrhagic cyst. As you know, for the best surgical treatment of endometriosis, usually it's better to do a wide excision, means remove the endometriosis as much as possible when it is very safe without damaging the adjacent organs. That is very important, that we remove endometriosis very thoroughly without causing any harm to the organs we are adjacent to the endometriosis lesion. One area that this wide excision and removal of the endometriosis could not always be good and actually sometimes could be bad is ovaries. Treatment and removing of wide excision of endometriosis of the ovaries, especially in younger patients who want to have children, or patients who do not want their ovarian function be compromised, the wide excision could be a very bad idea. And today we have a guest speaker and his guest. The session is being led by the world-renowned GYN oncologist and endometriosis specialist, who is also a professor at Cornell and NYU, and happened to be my brother, Dr. Far Nejad in Manhattan. He is going to lead the session with his guest and address this important issue. We thank you very, very much for your participation, and we guide you to the endomarch.org for the other sessions, and thank you. And Dr. Far Nejad is going to go ahead and take over for the rest of the program. I will meet you again at the end of the session to let you know about the next month and the coming month, what other programs we are having in preparing it for you. Thank you again, and we appreciate all of your support of the patients with endometriosis, everyone. Thank you.
Thank you very much, Cameron. Good morning, good evening, or good afternoon, no matter which part of the world you are. It is a pleasure to be the director of this session, and I would like first to thank our panel for today. Two of our patients. First one is Marketa Janska, and the second one is Jennifer Carlotta, that they will share with you or with us the journey about endometriosis. Then we have Dr. Shiva Talebian, board certified reproductive endocrinologist and infertility in New York City. And then we have Dr. Daniel Zeidman, known reproductive endocrinologist and infertility in Israel, to share with us his opinion, and we discuss about each topic. Then we have Dr. Shiva Talebian, one of my fellows that share with you her opinion about her experiences, and Dr. Mankan Tabali and Dr. Shruti Agawala, Dr. Cameron Nejad fellow. Briefly about ovarian endometrioma or endometriosis or chocolate cyst or hemorrhagic cysts. I give you a little bit background before we go to the discussion about this topic. Briefly, endometriosis could be superficial in the peritoneum, almost any part of the body, or it is called infiltrative, which is deep invasive to the tissue, or on the ovaries, could be, again, superficial or infiltrative. But one specific thing about the ovary is that the endometriosis on the ovaries could cause a cyst that almost rarely we could see any other parts of the body. So, and the importance about this, the endometriosis on the ovary, is that besides causing other issues like pain, infertility that you could see with peritoneal endometriosis, could cause effect on the function of the ovaries and affects the hormonal production of the ovaries. Also, the issue that sometimes could become cancerous, that I will discuss it myself later. So the issue of the removing the endometrioma, when to remove it, and how to remove it is the subject of the discussion between infertility specialists, gynecological oncologists, and other physicians. That is briefly about this topic. As I mentioned, this condition could cause infertility, could cause pain, or sometimes the patient could not have any symptoms, and incidentally was found during the regular gynecological examination or for evaluation of other conditions. So after this brief introduction, I would like to start with one of our patients, Marketa Janska. She was one of Dr. Cameron Najat's patient and share her journey with us and her experiences.
Yes, hello. It's nice to see everyone. Thank you. My name is Marketa Janska and I'm a patient of Dr. Najat. My surgery took place around 3 years ago, and now I have a 2-year-old little baby girl sitting, playing with the little train wheel. Yes, honey? 1 second. Okay. I was trying to get pregnant in 2015 for about 3 years, and then I couldn't get pregnant. We had to have help with the fertility doctor. I did IVF, but before my transfer, I had this weird feeling that I didn't trust my uterus, and I asked for an additional test, and we did a biopsy of my uterus, and it came back with the endometriosis cells. I was advised by my fertility doctor to reach out to Dr. Najat and schedule a surgery, and that happened 2 months later. I was very fortunate that it was fast, that I was able to come in, get it done, and next month I conceived naturally, and yeah, now we have a 2-year-old daughter. So this is a short, I guess the short version, but that's how it all happened. My period since the surgery has been mild. I'm still nursing. I think it's the result of coronavirus. So we're still nursing, and my period has been very mild and no pain whatsoever. So yeah, I'm very, very happy and very fortunate that I was able to get again with Dr. Najat. So thank you.
Marketa, thank you very much. And we would like to thank your husband, Ryan. So thank you for participation of the Stella, your beautiful daughter.
Thank you very much.
we appreciate if you don't mind hang around later on,
Yes.
if in case any of the audience or have any question, or I may ask you a question myself later. Thank you very much again.
Thank you.
So we go to the next speaker, Dr. Shiva Talabian. As I mentioned, the effect of the endometrioma on the ovarian function is the subject of the debate about when to remove it, how to remove it before the IVF, after IVF. And I have had the pleasure of working with Dr. Talabian for past several years, and numerous of the patients that they have gotten pregnant, and I really appreciate to be part of our team. Like Talabian, as I mentioned, she is a board certified reproductive endocrinologist, well known in the New York area, and we get referral from different parts of the even country to come to see her. Shiva, please go ahead and
okay. Great. Just everyone can hear me. Can you hear me okay?
Yes,
yeah?
Very good.
Okay, good. Hi, I'm Dr. Shiva Talabian, and I am a fertility specialist at CCRM New York in Manhattan. And as Dr. Najat said, I think increasingly I've been collaborating quite a bit with him over the past several years. And I've been practicing as a fertility doctor since 2008 and did my fellowship training before then. And I think that, you know, just anecdotally and personally in my career, I think that we are learning so much more about endometriosis. And I strongly believe endometriosis is way more prevalent than we originally thought. I have been seeing and noticing quite a bit in my patient population, especially those that are really under the age of 40 and even under the age of 35. There's a very high presence of endometriosis in these patients. As well as I think endometriosis is the culprit of a lot of what we call unexplained infertility. So 20 to 30% of you know, patients are diagnosed with unexplained infertility. And I really think that if we did surgery on those patients, many would have endometriosis. So just to briefly talk a little bit, you know, we have patients who come in and I do an ultrasound and I say, wow, I think, you know, you have an endometrioma there. You see the endometriosis on the ovary. And I think the question as to, do they go straight to surgery? Do they do fertility treatment? It's not a straightforward answer. I think it depends on the patient's history, her age, the size of the endometrioma, the appearance of that endometrioma. Is there anything concerning about it? For sure, if there's anything at all radiographically that looks concerning, that those patients would go straight to surgery before any fertility treatment. However, in some of our patients who we see the endometrioma, it's not very big, it doesn't have any concerning features on the sonogram, and they have very good ovarian reserve, meaning a good follicle count. Oftentimes we'll counsel them, especially if they've had infertility for quite a bit, to maybe do some IVF, obtain some embryos, chromosomally screen those embryos, freeze those embryos. And then when we feel that we have enough embryos frozen, to go and do the surgery and really clean it all out and then do the implantation. And we're finding that, you know, a high rate of success when we really clean up that endometriosis before they do the implantation. So, you know, and then there's other patients like Marquetta where they present with this unexplained infertility, they do IVF, they make good embryos, and perhaps they even transfer a couple and they're not getting pregnant. Or as time goes on, we highly suspect that maybe there is endometriosis, and there are these biopsies that we can do where we're checking for the different markers of endometriosis and then potentially doing surgery before they do the implants. So I will say that more and more I am sending my patients, as Dr. Najat can tell you, to do surgery at some point. Again, if they are doing IVF and perhaps not making good embryos or embryo quality is poor, sometimes I'll refer in that scenario, versus getting the embryos, freezing the embryos, and then doing a really good endometriosis surgery before the implantation.
Well, thank you very much. One of the issues that some reproductive endocrinologists arguing, or is it debatable, is the size of the endometrioma, and also if the patient has pain or not. What are your thoughts about that?
Yeah, absolutely. So when patients come in and it's, you know, a pretty small endometrioma, maybe less than 4 centimeters, they have, you know, they're not having significant pain that's influencing their lifestyle, then, you know, I think in those cases, then, and again, that the ultrasound shows this endometrioma not to have any concerning features, I think in those cases, perhaps they might pursue the fertility treatment first. But most certainly, if they're having significant pain, if it's sizable, you know, definitely over 4 or 5 centimeters, I much prefer that get it taken care of before the pregnancy is established, because obviously there's concerns that, you know, the estrogen in the first trimester, then the pregnancy, these endometriomas can grow, they can change their features on the ultrasound and look a little more concerning. And then, you know, the worst case scenario to me would be that endometrioma rupturing or becoming symptomatic during the pregnancy, and now this person needing emergency surgery when we could have taken care of it in a much more controlled manner.
Thank you very much, Shiva. As you mentioned, I just want to emphasize what Dr. Talebian said, because I'm sure we may have some physicians listening to this webinar, that they look at the characteristic of the endometrioma, because I have had endometrioma of 3 centimeters, and it had a nodule inside of it that turned out to be a cancer. And the patient actually was 29 years old. So although the size is important, the bigger the size is, more problematic. But besides the size, also the characteristic of endometrioma is important, that when the ultrasound performed and there is a nodule inside of the endometrioma, and then you have to be sure this is not some sort of cancer. And as sometimes we order MRI to differentiate between the blood clots and a real nodule that has to be operated. We should not ignore this issue. Thank you very much, Dr. Talebian.
Thank you.
Now, sure, if you don't mind, hang around. So I'm sure we'll come back later on to address other issues. Thank you very much, Shiva.
Absolutely, I'll be here.
Yeah, thank you very much. So now we go with our next patient, Miss Jennifer Perlata. This is a common Najat patient that also she shared with us her experiences. Jennifer?
Hi, everyone. Could you hear me okay?
Yes, thank you very much.
Okay, thank you for having me. So I'm 21 and I've been dealing with endometriosis since I was 9 years old, although I wasn't diagnosed when I was 9. I started my period when I was 9 years old, and ever since then, it has been a struggle. I have had missed opportunities and missed work. I have spent many days, nights, and like a lot of hospital visits, just to be told nothing was wrong. It was going back and forth between doctors, emergency rooms. We tried everything. I was put on so many different birth controls from about 9 years old when I started my period to, I want to say like 13 or 14 years, I tried many different birth controls to control my periods, so heavy periods that lasted weeks and made me spend my nights in the hospital in crazy pain. No one believed me. You know, doctors would be like, oh, that, like, you know, that's what a period is. That's what being a girl means, like periods. This is, you know, this is the life. But I believed otherwise. And so did my parents. So fast forward to when I was 16, we tried birth controls all the way till then. We're like, you know what? This, like, something's not right. So I go to Stanford at age 16 and found an OBGYN in which she did so many, like countless ultrasounds, blood works. I described like my pelvic pain, my body pain, worst cramps ever. Like I would describe it to people and be like, it feels like I'm in birth. I've never had a baby, but I'm pretty sure the pain is close. So I had bad leg pain, back pain, pelvic pain, like to go to the bathroom, the pain was just unbearable. So she had said, you know what, let's schedule surgery and like see what it is. And my first surgery with her, she had took me in and she had said she found endometriosis, but she did not get it all. So I was just thankful to have an answer at that age. At 16, I knew nothing about it. I wish I would have had more support, knew I wasn't alone, and be more educated on what endometriosis even was. Again, I was a little girl with no idea, but I knew that I was in lots of pain. So at 16, my first ever surgery to find out I had endometriosis, and I would say it helped for a little. About a year ago, at age 20, I sat at my job and I said, oh my gosh, I'm in the worst pain I've ever been. It was back to back missing work again, like coming home and just being in pain, laying in bed, sitting in my car, just like, should I go to the emergency room? Should I not? I went to the emergency room a lot last year. And I'm like, I'm pretty sure my appendix burst, but that was not the case. They did a blood work again, like nothing's wrong, you're fine. Here's a shot to like make you feel better and go home. So I sat on my computer one day and I'm like, I am losing hope. Like this is all back again. I sat and searched up the best endometriosis doctor in the world with no hope that I would find Dr. Cameron Najat, literally 2 hours from my house. So that was like amazing. And I started reading his page, Dr. Cameron Najat's website page. And I'm like, wow, this is me. Like all these symptoms, like this is what I have. I knew I had endometriosis, but like my doctor never followed up with me. She was also just an OBGYN. She was not a specialist in endometriosis. So the fact that I found Cameron Najat, who specializes in endometriosis, and cyst on my ovaries and just everything. From the moment I made an appointment and got in with him, the first thing that he had told me was, the pain is not in your head. Like this is real. You are feeling like what you're feeling is real. Like your emotions are valid. And it was just so nice that I found him because he believed me and he believed that my pain was real. And 2 months later, I go into surgery with him. And my biggest fear was not being able to have kids. So when I first seen her, I'm like, you know what? Like, I want to be able to have kids. I'm nervous. I'm not going to be able to because I've had endometriosis since I was 9. It's been a journey. So when he did his surgery and I got out, the first thing he told my mom was she had endometriosis everywhere. I removed all of the endometriosis and she does not need to have kids right away. That was like a huge relief off my end because that was my biggest fear. And just to hear that he removed all the endometriosis, it's been about 11 months since my surgery with Dr. Cameron Najat. And to say the least, he has changed my life. I deal with illness still, but I would say I don't deal with it as heavy as I used to. I feel like I'm living somewhat of a normal life now. And it feels so good just to feel like I feel healed, a healed woman. But seriously, Cameron Najat has changed my life. And I share my story today to bring awareness to endometriosis in hopes to find a cure, to educate, empower women. And hopefully the next person that goes through this doesn't have to wait 7 to 10 years to be diagnosed like I was. So yeah, thanks for allowing me to share my journey.
Thank you very much, Jennifer, for your deep-hearted experience that you had. And this is not, for us, it is unfortunately, it's not new. Every day we hear the same stories, and that is the reason that we are here. So let me ask you, if you have 2 suggestions for the women in your age or older, younger, you have 2 things to tell them. What do you tell them when you have the pain or experience?
My first one would be to listen to your body because that's what I have learned throughout this journey is to Listen to your body. Whatever you're feeling is real. And I know there's doctors that aren't as educated on, yes, they're helpful, but endometriosis is not really known. A lot of OBGYNs don't know a lot about it. So it's like, listen to your body and trust, like, painful periods are not normal, and having to be in the emergency room in pain is not normal. So trust and listen to your body. And my second suggestion would be to not let the illness define who you are. So no matter, for someone who has endometriosis or thinks you have it, like, it's something you have to live with forever, yes, but we are strong, women are strong, and we will roll it, we're good. So that would be my two suggestions. Listen to your body and don't let this illness define who you are.
Thank you very much. That is exactly what I was going to ask you, is that listen to your body. Don't let people say, oh, that is normal. Your mom had pain. Oh, that every woman has pain every month. The pain is not normal. You have to address it. This is a wrong teaching, understanding that unfortunately has been in the mind of the society and has been passed on generation after generation. And again, thank you very much for saying that unfortunately a lot of physicians are not familiar with this condition, and you take the control of your own health and bring it up to the attention of the physician. And if it is not amenable to your listening, look somewhere else. So thank you very much.
I agree. Thank you for having me.
Of course, thank you very much. If you don't mind, hang around here if in case. So thank you very much.
I will. Thank you.
So as was discussed before, a proper removal of the endometrioma is very important. The goal is that remove it properly while you are avoiding damaging to the ovary. And that it is an art, in my opinion, and science. Why I say it is science? We published several papers and we describe the origin of this large endometrioma is ovulation. That combination of the ovulation cyst, which is called corpus luteum, with endometriosis of the surface of the ovary or endometriosis of the pelvic side wall, they get together. And if the patient is not taking any kind of hormonal suppressive therapy like birth control pills or other hormonal suppressive therapy that prevents ovulation, this corpus luteum gets together with endometriosis of the cortex of the ovary, the surface of the ovary, and cause an endometrioma. And if you understand this way that endometrioma or chocolate cyst is formed, then you know how to prevent it and how to treat it. What do I mean to how to prevent it? That if the patient has endometriosis and has surgery, and if he doesn't want to get pregnant, you put them on hormonal suppressive therapy to prevent ovulation, this patient would not develop another chocolate cyst or endometrioma. And that has been our experiences for many, many years. The next thing is that if the patient wants to treat them, if you know about this way that endometrioma is formed, you know how to treat it. Now, I will ask Dr. Sharoti Agawala, Dr. Cameron Najat's fellow, to tell us how do you treat endometrioma?
Good morning. My name is Shruti. I'm one of Dr. Najat's fellows. I've been working with Dr. Najat for over a year now. I'm a second-year fellow. So on a daily basis, I think on a weekly basis, we treat endometriomas very often. We go into surgery knowing that the patient has endometriomas, or we go into surgery and find that the patient has a small endometrioma or an infiltrated endometrioma that me as a fellow, I'm unable to see, but then Dr. Nishat is able to see that it is right under the surface of the ovary, and then he's able to excise it. But most of the time, we try to just excise the endometrioma and the cyst capsule without injuring the ovary, because most of our patients are young women who are looking to help preserve their fertility. So Dr. Najat has been paramount in teaching us as general OBGYNs how to excise the endometrioma and the complete cyst capsule without injuring the ovary. Because I think as a resident, when we would see really large endometriomas that were basically encompassing the whole ovary, our attendings would mainly take the whole ovary. So over the past year, we have seen some pretty hard cases where he was able to teach us how to properly and safely excise the endometrioma and the capsule without injuring the ovary. So it's been a great learning experience with him in the past year to be able to see type 1 endometriomas, type 2 endometriomas, and also how to go about taking out the adhesions and treating the endometriomas and helping to save the ovary, the healthy ovarian tissue, as much as possible.
Thank you very much. If you want to give a tip to some physicians that they are watching this program, if they want to remove the endometrioma as a surgeon to avoid damaging the ovary, what do you tell them? I mean, you are a young physician. How do you tell them to do that?
So I'll tell what went through my mind when I started the fellowship as, you know, a resident who had just finished general OBGYN, and after a year with Dr. Najat's fellow, what goes through my mind now. So before, when I first started and I would see large endometriomas with bowel adhesions coming up to the ovary where you couldn't even see the ovary, all you saw was, you know, the whole endometrioma in the whole pelvis. In my mind, I used to think, I have to take the ovary is not going to survive. So the first thing that went through my mind is a little bit of freaking out to be like, you know, I just got to take the ovary. Over the year, as I have gone by, my thought process now, when I look at bad cases, is I try to think what Dr. Najat is thinking. And instead of thinking that I need to take the ovary, I start thinking how he's going to plan to systematically, slowly, carefully take down the adhesions, find the ovary, plan how he's going to excise it, and then goes about to do it. So I would say my one tip is don't freak out and jump to the conclusion that that ovary needs to be taken out because there's no way to save it. If you just do it systematically and do it one at a time and do it carefully and slowly and take down the adhesions and look at your whole picture, I think you'll be able to plan a better excision surgery rather than the patient just losing the ovary.
Thank you very much. Thank you very much for this important step. So I just want to share with you, because I'm a GYN oncologist and also a background of infertility and endometriosis specialist. And it is not unusual that patient has endometrioma and chocolate cyst. By the way, the reason we call it chocolate cyst, because this endometrioma, the fluid inside of it is old blood, and the color is old blood, is dark like chocolate. So that is the reason we call it chocolate cyst. So just want to just explain that one. And then, unfortunately, one of the tests that it is done frequently for ovarian cysts, or it is called CA-125, and it is frequently elevated. And the combination of the elevated CA-125 and the cyst, people think it's cancer and they refer them to GYN oncologists. And a lot of my colleagues, unfortunately, although they are excellent surgeons, they may not familiar with the pathophysiology and the way that endometrioma is formed, and maybe easier for them to remove the tube and the ovaries than to save the ovaries. So when I said dealing with endometrioma is a combination of the science and art, is that you should know why endometrioma is formed. Frequently is the scar adhesions or scar tissue is involved, especially on the left side is attaches to the bowel. A lot of physicians are afraid to tackle this cyst because they're afraid to the bowel, and rightfully that is correct. That is, they should stop. So it is better to stop and refer the patient to proper surgeon that doing haphazard surgery, removing part of the cyst or damaging the bowel. So that is important, that as a physician, as a patient, if you are diagnosed to have endometrioma and your physician tells you have endometrioma and he or she decides to operate or decides to refer you to somebody, you're asked the question, who is this person? What is the experiences? And look for that right person, because that is very important. You don't want, as Dr. Aguilar said, to remove the tube and the ovaries. Also, you don't want to get to the complication. So after this discussion, we go to the next speaker, Dr. Daniel Zeidman, a great friend of ours for many years, famous internationally for his pioneering work. He has more than 250 peer-reviewed papers, chapters, and to talk to us about egg freezing, role of egg freezing, embryo freezing in women with endometrioma, endometriosis. Danny, thank you very much. Good to see you after a long time.
Thank you. I hope you can hear me well. And I'd like to thank the Najat brothers who not only trained me well, but also really the #1 experts or the #1 to 3 experts of endometriosis. And I think they're doing a great job of bringing news on endometriosis. Personally, I'm both a very active IVF specialist, and also I'm a co-founder of a company called AIVF, where we're trying to bring artificial intelligence for the help of IVF and improving women's health, and really have some very exciting developments. I'm sure we'll be able to talk about this another day. Regarding egg freezing, it's an extremely important subject for endometriosis. Actually, the Israeli government recognized it as such an important issue that they're actually completely funding egg freezing for patients in Israel. This just comes to show you how important it is. We know that there are 2 major factors that affect future fertility. One is age, and we know that from the age of 35, fertility starts declining slowly, from the age of 40, declining quickly, and also any damage inflicted on the ovaries. Now, this can be directly inflicted by the endometriosis itself, you know, the lesions or the endometriomas, and also by, unfortunately, by surgery. This is also why it's so important to go to an expert surgeon when you're treating endometriosis, because when highly expert surgeons like the Najats operate, the likelihood of future damage to the ovaries, which will affect your entire life, is much smaller. So currently, what we suggest is if you've reached the age of 30 to 35 and you haven't yet completed your fertility plans, you should at least consider freezing eggs. If you had multiple surgeries, or if you are planning future surgery, this is even more important to you. Now, 2 things you have to remember. One, you already mentioned age. So the earlier you freeze your eggs, the better. And currently, we recommend freezing around not after 35 or 37, when fertility starts to decline significantly. And again, if any surgery is planned, this would be a good time to think about first freezing eggs and then doing the egg freezing. We know for sure that after prolonged endometriosis and after repeated surgery, there's a big decline in fertility. We always tell our patients, go check your fertility status what we call the ovarian reserve, which actually means how many eggs do I still have in my ovaries, and you can do this by two major ways. One is ultrasound, where we call it antral follicle count. We count the small follicles at the end of the period, or you could do an AMH serum test, which is a simple blood test, not too expensive and highly predictive about the future. It doesn't tell you if you're going to get pregnant now or not, but it is going to tell you, should I be quick in freezing my eggs? We usually recommend freezing at least 20 eggs, because the younger you freeze and the greater number of eggs you freeze, the higher your chances. Again, you shouldn't get obsessive and start freezing hundreds of eggs, but if you are around 30 to 35, we'd recommend freezing at least 20 eggs. And if you're over 40, if you manage to freeze 40 eggs, you'll be in an even better position. And we estimate that if you're around 36, you probably need 10 eggs to have a 50% chance of having a child, or maybe double the number, 20 eggs for an over 90% chance. Well, if you're 39, you probably need about 16 to 20 eggs. So age is a major factor. And of course, there's a matter of luck, because some patients freeze 20 eggs, and this is enough for them. I just had a patient who froze her eggs in my clinic when she was 40, met her boyfriend when she was 45. They decided to have a child together when she was 48. We defrosted only 3 eggs, and she just delivered a baby. And we have multiple examples like that, where even just 2-3 eggs. I had another patient with 39 frozen eggs, and we again defrosted 3 eggs, and she delivered twin girls. So this technology does work, and you should definitely consider it if you haven't completed your family size. I mean, you can do it even if you have 1 or 2 children and you know for certain that you want another child. Now, cost is always an issue, but actually the big cost when you freeze eggs is sometimes how much the clinic charges for saving your eggs per year. Now, if you're very young and you start freezing your eggs at a very young age, this might be, should be calculated, you know, how many years of freezing. And when they tell you how much they charge for the egg freezing, always ask them how much I will be paying for the storage, because sometimes that's where they're making their money, okay? And it's a very competitive market, which is good news, because you can shop around and you can ask clinics, and it's not a technique that you need a huge experience. Unlike the surgery that we mentioned, with only a few masters of the trade, in egg freezing, any good IVF specialist can do this, and technically it's not difficult to freeze eggs. So it's definitely something you should be considering if you haven't completed your family. And again, especially you should consider this if you're doing surgery. Another interesting tip that I could mention, some patients are undergoing anyway surgery for endometriosis, and if you're very young, this could be also an opportunity to freeze fragments of the ovarian cortex, which we know are very rich with the follicles. You could freeze them, and then you could put them back years later. And sometimes, if you're anyway undergoing laparoscopic surgery, you could consider this. Again, this is something that not every hospital knows how to freeze ovarian fragments, but if they have a big oncology service, or they can also ship it out. I mean, any doctor can freeze these fragments, and if he gets the right instructions, and defrost them and freeze them and store them in a big fertility center. So these are my main points, and I hope I was instructed.
Danny, thank you very much. That was the excellent guidance, excellent information. And thank you very much for mentioning about the ovarian tissue freezing. I know that maybe in Israel is more common than in United States. Actually, we have these opportunities in one of our hospitals, actually both of the hospitals, in Cornell Hospital and also in NYU Winthrop, to egg freezing, and I work with this, our colleagues frequently, because of some of the patients have cancer. So it is easier for us to guide the patient for egg freezing. regarding endometrioma, which patients do you recommend to have egg freezing? I mean, younger patients, when they go for surgery, you recommend them to have egg freezing, or because the cost is an issue.
First, I think bilateral ovarian endometrioma is an important point. I mean, if it's a patient that's undergoing surgery for the first time and only on one side, only one ovary might be damaged, I think they should be less worried. But if this is repeat surgery, especially surgery that was done on both ovaries, I think these patients should, at any age, consider freezing eggs. And of course, the older the age, once they reach 35, 36, where age plays a major factor in the ovarian reserve, they should consider it. But bilateral surgery is something that should raise a warning sign. Are they damaging my ovaries, and should I freeze eggs? And again, always think, before you do surgery, it's not just relief of pain, it's also damage inflicted. That's why it's so important to do this with a highly trained surgeon that knows not to burn up your ovaries. And I've seen some bad surgeries, unfortunately, and especially the outcomes. And it's amazing what the difference is if you know really to dissect the endometrioma out with minimal damage, thinking that this 18-year-old girl still needs her ovaries for the next 20 years. So this is very important.
Thank you very much, Danny. I appreciate that one. So I know I like to ask Dr. Shadi Siraji that she is my fellow and has been working with me for past more than a year, to share with us about her experiences about dealing with endometriosis and endometrioma. Dr. Siraji.
Hi, everyone. Before joining Dr. Najat during my residency training, I had learned about endometriosis, and at the time I thought that my knowledge was adequate enough. Little I know, a year and a half later, I realized how superficial that knowledge was under care of Dr. Najat, and his tutelage. I've learned so much, and it broadened my knowledge about endometriosis. I was not aware of the effect of endometriosis, the extent of it, and how the patients suffer from the endometriosis. I was not aware of the connection of the endometriosis, the extent of it on infertility. I was also not aware of the malignant transformation of the endometriosis. The first time that I heard about it was when I started working with Dr. Najat, and which it taught me how important it is to
I think, Shadi, unfortunately, your camera got frozen. Okay, I take over here, finish what Dr. Shadi Siraji was saying. So actually, it's a good time that I address this issue of malignant transformation of the endometriosis. And briefly, the same way the lining of the uterus, called endometrium, could become malignant and could develop different types of the histology of cancer. The endometriosis tissue, which is similar to the lining of the uterus, also could become, unfortunately, malignant or become cancerous. And briefly, the reason behind it is combination of the high level of the estrogen and also inflammation. Endometriosis is an inflammatory process, and the high level of the estrogen on the ovary or even on the endometriosis implant could cause this transformation. So fortunately, not all the patients with endometriosis the cyst become cancerous, but unfortunately, this possibility exists. Women with endometriosis, the chance of developing cancer is twice as compared to general population. So it is not very high. However, you have to know about it. As I said earlier, if the patient has chocolate cyst, endometrioma, and we decide not to operate on it, we believe any endometrioma has to be operated on no matter how small it is. You operate on it because endometrioma rarely is by itself. Always there is endometriosis somewhere else. And because we don't know if the endometriosis could cause pain or not, and we believe the earlier you remove the endometriosis, you have prevented this endometriosis getting worse. So what our philosophy is that even the small endometrioma has to be operated on and killing the endometriosis, other parts of the pelvis. If the patient is not ready to get pregnant, put them on hormonal suppressive therapy and follow them carefully. This is the way that we recommend. This is our policy, similar to patients with cancer, that we follow them closely, because unfortunately cancer could come back. Endometriosis frequently is a recurring condition. So we believe you have to follow the patient carefully. If doesn't want to get pregnant, put them on suppressive therapy and follow them. And if the patient has any kind of symptom, even if they have gone to menopause and had history of endometriosis, and now comes to you and she is complaining of the pain or unusual condition, endometriosis should be in your back of your mind. Unfortunately, endometriosis, any part of the body, it could become malignant. We have seen it, endometriosis of the skin become cancerous, on the bowel frequently could become malignant, on the bladder we have reported it, even in the liver, in the lung, all could become malignant. As I said, the possibility is low, but unfortunately the possibility exists. And that's one that I wanted to keep in mind to know about it. So we have only a few more minutes. I just want to ask Dr. Talebian, any last thought, Dr. Talebian? What do you think about the egg freezing and tissue freezing that Dr. Zeidman was saying?
Yeah, hi, sorry. Absolutely, definitely in any of these women with known endometriosis, and again, as we say, it's a highly enigmatic disease, right? There's people with severe endometriosis who don't have infertility, but the assumption should be that this endometriosis will at some point potentially negatively impact the egg quality and their chances of getting pregnant in the future. So we are absolutely big advocates of egg freezing, potentially embryo freezing, depending on their exact specific history. And, again, we have, many, many women coming in to freeze their eggs, pre-surgery, sometimes post-surgery, if they didn't know they had endometriosis until they did the surgery with you. But I agree with, all of the discussion today is highly, highly relevant. And as I said, just even me in my own career, I think we are learning so much more about endometriosis, and it's highly critical, especially, for those of us who have daughters and young women, in our lives, not to ignore a lot of the symptoms that they have. So I really appreciate the patient stories as well.
Thank you very much, Dr. Talebian. And now I'd like to ask Dr. Tavalai, a fellow of Dr. Kamran Nejat, to share with us her experiences. Dr. Tavalai.
Hi, hello.
Good.
Hi, so yeah, I joined Dr. Najat's team almost like 2-3 months ago. I did 2 years of pathology residency before at Stanford before I do my OBGYN training. And it's actually been really fun because like 4 years ago, I used to get all the specimens from Dr. Najat's group and look at them under the microscope to find the endometriosis, which would be pretty amazing for us because we could basically just compare the specimens that we got from like different doctors. And I see Dr. Najat when he's talking to the patients and counseling them about it all depends on the surgeon and the experience of the surgeon to see the tissue and be able to do the endometriosis surgical management in the best way possible because yes, we used to get all the specimens from different doctors and you see based on their experiences, you actually see the endometriosis tissue on the smallest tissue that you get. And now that I'm on this side and I'm in the OR with him, he points at some lesions that all of the new fellows and probably like the old fellows as well just look and say, oh, this looks like normal tissue. However, because Dr. Najat is pretty experienced, he can see the lesions and just like excise them and we send it to pathology and the results come back and endometriosis, which is pretty exciting for me to be on both sides and see the surgical and also like the pathological findings of the endometriosis. And I think it's very, very important for everyone who's going under surgery to make sure that the surgeons are pretty experienced in endometriosis. As Dr. Saraji was saying, during our residency, we get a lot of training. It's just like an OBGYN residency. And there's like a lot of different things to cover during the residency. And endometriosis is just like a very small portion of it, which I think it's really good that the generalist OBGYN can diagnose the patients and just refer them to people who are a lot more experienced and are specialists in endometriosis to be able to follow them and help them both in terms of pain management and infertility.
Thank you very much, Dr. Tabalai. Cameron, can you see me?
Yes, I can see you. Yes.
Thank you, man. For some reason, my screen turned off. So I'd like to thank everybody, Marketa, Jennifer, Dr. Talebian, Dr. Zaidman, Dr. Tabalai, Dr. Saraji, for your excellent points. Now I turn it over to Dr. Cameron Najat to finish the session. Thank you very much, everybody, again, and have a nice weekend.
Well, thank you very much, Dr. Najat and his wonderful guest for a very enlightening and educational session regarding management and treatment of ovarian cysts, endometriomas, and egg freezing, infertility, and pain. I thank Dr. Najat, his guests, Dr. Talebian, and Dr. Seidman, Marketa, and also Estella and Ryan and Jennifer. Also, I'd like to thank Dr. Saraji, Dr. Tabalai, and Dr. Shruti Agrawal for their participation and for assisting to raise the level of awareness about endometriosis. And most importantly, we thank all of you, the viewers who are interested to change the status quo for endometriosis, finding a cure for endometriosis, and end the dynasty of endometriosis on the lives of patients with endometriosis and their families. We don't want to see any more young women having hysterectomy, removing their tubes and the ovaries removed, at a very young age, that unfortunately still we see that sometimes. Sometimes there is absolutely no choice. I do understand that. But nowadays, there are many, many choices. Next month series are going to be about issues that has for years confronted couples who have tried to have children and they are told everything is normal. All of their tests are all normal. They have no pain. Husband is okay. The wife is okay. The partner is okay. All the tests are normal. They have had all kind of tests or have done all kind of fertility treatment, failed IVF, and they don't get pregnant. Often these patients have endometriosis, and we have wonderful guest speakers that they are going to address with patients about all of this. Meanwhile, if you are interested to learn more about endometriosis, go to endomarch.org. If you go to endomarch.org, there are the webinars, and the webinars you can find your session of interest. Also, if you think you or somebody may have endometriosis, there is an app that it is free around the world. It is called Nejat Endometriosis Advisor. It is on endomarch.org. You can find and download that. We thank you very, very much again for your attention. And until the next month, forward we go, and have a great time. Bye-bye.
Thank you.
Hi there. I'm Dr. Charles Miller from Chicago, Illinois, and I am certainly honored to be asked by Dr. Cameron Najat to present to you on behalf of the American and Global Congress of Endometriosis Subspecialists, AGCES. The topic I will present to you today is on the surgical management of the ovarian endometrioma, both pearls and pitfalls. Many years ago, Dr. Ludovico Muzzi and I wrote an opinion article in JMIC entitled "The Singer, Not the Song." What we talked about was the need for good surgical technique when dealing with the ovarian endometrioma. And that is really what I want to talk with you about today. We know that surgery can have a deleterious effect on the ovarian reserve. That is a negative effect on the anti-Mullerian hormone follicle numbers and overall clinical success because of surgical damage to the ovary. The one instrument that has been implicated more than any other in terms of causing problems at the ovary is bipolar forceps. If you look at this study, looking at a group of studies and looking at effect on AMH, every one of these cases involved bipolar cautery, stripping and bipolar cautery for hemostasis. The truth is that the destruction of the tissue is can be local inflammation problems, and certainly because electrical energy travels to the path of least resistance, it will go toward the vascularity and have a negative effect on vascularity. So pearl number one, put your bipolar forceps away when dealing with the ovarian endometrioma. Think about the use of plasma energy for desiccation. This was a study by Horace Rahman looking at endometrioma via cystectomy and plasma ablation. And if you look at the antral follicle count on the non-operated ovary and the operated ovary, you will see less reduction in the side that utilize plasma energy. In another study, looking at issues in terms of plasma energy versus cystectomy, you see here that pregnancy rates at 24 and 36 months are very similar. Now, we are utilizing plasma energy now with our team in terms of ovarian endometriomas. But here actually is a surgery performed by Dr. Roman. And obviously, you go in and you open up the endometrioma and then irrigate. Instead of now excising the cyst, you utilize plasma energy, RF frequency energy, and just desiccate the area. You can see overall pregnancy rates are very similar in the two techniques to cystectomy versus plasma energy. Here is yet another study from Roman's group looking at plasma energy versus cystectomy and drainage. Although live birth rates are very similar between all the groups, as is miscarriage rate, one can see that the revised AFS score was far worse in the plasma energy group and the drainage group versus the cystectomy group. Moreover, there was a lot more bowel involvement. So if you have comparable rates, but the plasma group was a much worse patient population, one has to extrapolate the advantage of using plasma energy. Well, another technique would be to use cystectomy via laser, the carbon dioxide laser. If one looks at results from Paco Carmona's group, there were similar results in terms of overall pregnancy, etc. However, there was no real difference at 60 months in the two techniques, cystectomy versus carbon dioxide laser, but there was actually less recurrence at 12 months in the cystectomy group. So short term, cystectomy did better, but overall, there was no difference than simply doing vaporization than there was in the cystectomy group. There has been another study looking at the carbon dioxide fiber laser compared to cystectomy. Recurrence rates were similar. The most important indication why there was recurrence was size of the endometrioma. Pregnancy rates subsequently between the two groups also were similar. Now, interestingly, spontaneous pregnancies was higher in the stripping group. But overall, carbon dioxide certainly holds its own with the cystectomy group. None of these techniques, the carbon dioxide laser vape or using the fiber, shows an actual improvement over use of cystectomy, however. Now, this is a technique championed by Jacques Donnet. And basically what he's doing is going in and draining the endometrioma. He then goes in and performs most of the cystectomy. So he's doing a combined cystectomy with desiccation via CO2 at the hilum, at the base. So instead of traumatizing the base with by excising, he simply goes in and desiccates this small area. So it's not a total desiccation, but it's not total cystectomy either. And as you can see, overall success has been very good. Another very popular technique is the 3-stage management for the endometrioma. That is to go in and first drain the cyst, treat with a GnRH antagonist, and then open up the cyst and desiccate the area of endometriosis after 3 months. This has shown to be better than a 1-stage technique. My concern, however, is the cost. Here in the United States, we would have a great deal of difficulty doing a 3-stage technique because of cost. There have been multiple studies looking at AMH and suturing compared to using bipolar. It appears in many of the studies that going ahead and using suturing will improve overall AMH rate over bipolar. But this is not across the board. But in general, there is improvement. We feel that this is a technique that is an improvement over bipolar desiccation. But it's not a technique that across the board offers a significant improvement in AMH. As you can see, I'm taking out this cyst. I'm just going to go ahead and advance it. Now we're suturing after we've taken out the cyst. I have a small defect that I first go in and suture. Now, once I did that defect, I do a running purse string around the cyst. And so I'm going layer after layer after layer to finally put the edges together, which you see here. By doing this in a running purse string, I have found that I do not see to the same degree post-operative hemorrhagic cysts in the ovaries after I've simply sutured just the capsule. So if you have a big defect, I recommend, if you are going to do suture, and it is an improvement in my mind over desiccation, that you will do a running purse string, just not a purse string at the top. Another technique to improve ovarian reserve at time of surgery is to utilize a biocoagulant, to gain hemostasis with a hemostatic sealant. Flow seal was studied. In this study, compared to ovarian cystectomy and bipolar desiccation, the AMH decline was significantly greater in the bipolar coagulation group. I looked at another hemostatic sealant called Tisseel, which is a formulation of fibrinogen and thrombin, and went ahead and compared this to cases where I didn't need to use any treatment at all because there was already hemostasis on the in the cyst bed. Also compared that to suturing. And we found that it was the sealant group that performed best, that there was virtually no difference than with the group that did not require any type of treatment post removal of the endometrioma. And that was looked at as being significant. So we feel at present that our best technique would probably be to use excision until we reach the hilum and then utilize the plasma jet. By excision, we're able to get out the disease, lowering risk of recurrence, using Tisseel when we need to. But then as we get to the base right next to the hilum, we simply desiccate that area. One other technique that I will talk to you about is the use of ethanol. Ethanol has been utilized for the treatment of endometriomas. It appears that the best usage of instillation of the 95% ethanol would be approximately 15 minutes. Then it can be removed. I do recommend thoroughly washing of the bed post ethanol, and don't fill ethanol. You'll take out your fluid, measure your fluid, and then put back about 2/3 to 3/4 the amount of ethanol, and make sure you have a tight seal because you do not want to spill ethanol. Right now, it's being studied in Dubai with Professor Arnaud Wattiez. I look forward to his experience and to see if indeed use of ethanol sclerotherapy is worthwhile. So on that note, I would have to tell you, number one, stay away from your bipolar. Number two, going ahead and using a laser technique is similar to cystectomy and bipolar. Jacques Donnet's technique of excising and then vaporizing the base is promising. I believe that the use of a biosealant has been shown to be very successful in a few of our hands. We just need more people to study it. But today, I would recommend either utilizing the biocoagulant all the way or to desiccate with something superficial at the hilum, such as laser or plasma jet, but excising most of the cyst wall. I thank you for your attention.
So hello, my name is Roy Devi. I am a worldwide EndoMarch headquarters volunteer. I'm here today with the EndoMarch representative of Team Hungary, Adrian Salmon, who is also the board member of World Endometriosis Organizations. Once again, it's very nice to meet you, and thank you for taking the time today to answer some questions. To start off, how did you become involved with EndoMarch?
Thank you, and nice to meet you too. We are involved in EndoMarch since 2015, so almost 10 years. This was our biggest project in Hungary. This was our first EndoMarch event, and we made a very nice event in the middle of the capital of Hungary in Budapest.
Wow.
And since then, we are organizing this event from year to year. And now, I think for 4 years, this is all around Hungary. So we are making a roadshow during March.
Yeah, I heard about that roadshow. Could you tell me more about that?
Yes, these are events all around Hungary, in the biggest cities all around Hungary, and there are also big institutes about endometriosis or endometriosis centers. So we are invited doctors and different kind of experts also to the events to help women and the families dealing with endometriosis.
Yeah, that's really awesome that you have this event all throughout everywhere, so that it further, different areas, you have different audience. So it's nice to reach everyone and inform everyone, increase knowledge about endometriosis. So that's very
and
awesome.
We also record these events. I mean, the lectures and the conversations or the roundtable talks. And these are available on our YouTube channel or our podcast channel as well.
Amazing. Thank you. Along the same lines that we're talking about, how have other efforts increased or furthered endometriosis awareness in your area in Hungary?
We are working in this area since more than 10 years or 14 years. I had endometriosis. I was the first patient in Hungary who was operated with endometriosis, in deep infiltrating endometriosis by laparoscopy. And I met this doctor, Dr. Attila Bokor, and asked him about talking this endometriosis more. And he was very supportive. And for this time, or from this time, he is our biggest supporter. I'm as an expert. So we are working together in this awareness project as well. We have a lot of projects during the year. So we have not only the EndoMarch events in March, then during the year, the whole year, we have a different kind of projects. We have a hospital package. This is free for every woman in Hungary who is operated with endometriosis. We have different kind of goods and different kind of leaflets about endometriosis, which could be helpful during the hospital stay, after the surgery, and also helps by the recovery. This is a very popular package. This is available now, or we give it to at about 5,000 women in the last 1 year. I think it's a big number, and this is available more than 40 institutes or hospitals in Hungary. So this is one of our projects. We have Manshi box also. This is a small box for teenagers to help women with their first period, and because we think it's very important that know exact and important information about the cycle, about the menstruation, about maybe the problems also So we had to start this communication and awareness at the first stage, and this is, I think, the first period. And this could be also a nice thing, because we record that in a lot of in the life of a lot of women, the menstruation is a bad thing. So we would like to change this, how to have this better, maybe, or how could we a nice period during our life. So this is the second. We have a tax reduce. This is a special thing in Hungary. So if you have a workplace, you could get tax reduce. This is one amount, could be a one amount together per year. This is also very popular. You could get this if you have a surgery because of the endometriosis. We have YouTube videos or webinars, podcast talks during the whole year, and also have a support group. And the members are over 10,000 women or their family members, also maybe husband, mother, father as well. And in this group, we have also webinars. We have experts who can support the women living with endometriosis. I think these are our biggest projects. We are thinking about more and more. It depends on our capacity and our supporters, our fundraisers. And one more project is our Lucy application, because we made the application to help women.
Yeah, well, it seems like you're targeting a lot of, domains and demographics, which is very important, especially with the Mensi box that you mentioned, targeting adolescents and young individuals who have just started menstruation, and educating them, and, getting rid of that taboo and the stigma. All that is very important, and important in reducing diagnostic delays, in other words. So going back to the Lucy application, I heard about some of the Team Hungary's social media campaigns and cooperation with influencers, specifically the Lucy application. Could you share more about this campaign and the app?
Yes, we made this application because we would like to reduce the diagnostic delay, which is in Hungary 4 years, which is, I think, very special if we compare with different countries, because as I know, in a lot of countries, the diagnostic delay is 7 and 10 years. And in Hungary, this is 4. I think it's a big thing that we could reduce it in 10 years to 4 years, but we are not satisfied with this result. So that's why we made this Lucy application. Lucy application helps if you put data in it, your problems or your pain in it. The application alerts you that maybe you have problem, you should go to the doctor, and we can offer institutes, because you can reach our website, and our website you can reach the institutes. And now we would like to cooperate with more organizations, and I think in a few months, I hope in a few months, we will have more connect to the organizations, and they will put in this section that if somebody are using the application for Germany, she will reach, or she could reach the organization and also the doctors and everything in Germany. So I think it could be a very helpful thing. And next to this, we have a dietary block also in the application, which could help you monitoring your dietary things during the day. And also if you have problems with some goods, you can see in the application. And the application is the part of a big project, research project called Female. this is going on in 6 countries, but not only 6 countries, because the consortium partners are from 6 countries. But now in the last year, I think it's a very interesting project for outside the project as well. So more countries are connecting to the Lucy application and to the research.
Yeah,
Also, and yes, we had with a social media campaign. It was very interesting. It's called Vagina Bags, because we compared the women's health with the women's bag, because our women's bag are also a mystery. We didn't know or don't know what is in it, and maybe we could find something strange also, and that's why we made this campaign. It was very, the reaction was very, very interesting. I take this campaign to big conference where are almost doctors, and I showed at a poster section. And if you were at a similar congress ever, you see that you can see only words and graphicons on these posters, and this Lucy is a vibrant red, purple, and this you can see the vagina in a big picture, or seems like a vagina. And a lot of people were coming at, what's this? What are you doing? So we had this poster campaign, and the slogan was, "You should look deeper." And you can see if you click on the or photo shoot the QR code, you can go to the Lucy application and meet Lucy application. And we had a campaign with the influencers, famous influencers in Hungary, and they were talking about their cycles, their problems, and their connection with their bags also. And we showed the Lucy application to them also, and I think they really liked Lucy application. And from that time, they are using Lucy application as well.
First of all, I wanted to say I really love the analogy of what's in the bag. I just needed to say that. I think it's so clever, and it calls for a great campaign. And back to the influencers and their role in the Lucy application. I think it's so great that you guys are using influencers to begin with, because they reach such a large audience. I think in today's world, in today's society, using that method of using influencers and sharing with them your campaign and them sharing with their audience is really effective. So I thought that was very cool.
Thank you. We are working with influencers for 3 years.
Mm-hmm.
We had a campaign. It was very famous also. We had a nice connection with Hey Julie, and we made a video with her, and the topic was Lost Days. This was the video's name, Lost Days, because our agency find out that women living with endometriosis, because of the pain, are losing 1 year in 10 years period of their life. They counted this, so it's very impressive, and this was also a very successful campaign, and a lot of women this reach a lot of women also.
Yeah, I bet.
I think
that's really great. Yeah. I wanted to ask if you've been a part of or noticed any change to endometriosis policy. So just wanted to get in the policy aspect of endometriosis really quick.
In Hungary, we had a guideline accepted in this April, in 2023 April. So I think it's a huge success. It's similar to the ESHRE guideline as well. And now we are working on that the centers which are working and are available in Hungary. These are 6 or 8 centers around Hungary, could reach more people, or the people could get in, and they could have a better patient road. So we are working, we are work on this project now. We need money to the hospitals or to this project, but I think we have a good cooperation, and we have a good connect to the government, so they are very supportive. Before this acceptance of the guideline in March, we invited the most important people in this area in Hungary, and all of them come to our event on Sunday morning. So I think it shows that it's important to the government or the health committee also. So I believe that we can reach more in this field also in the next few months.
Yeah, you know, obviously, as you know, women's health has for a long time been overlooked. And to hear that your government is supportive and you have created this endometriosis guideline to be implemented in health institutions is very reassuring, and it's good to hear. And I can't wait to hear about what Team Hungary continues to accomplish in the future, and your efforts in raising awareness around such an important issue. And before we end, is there any last words you'd like to share?
I think the foundation's name is Together It's Easier Women's Health Foundation, and I think it's a very important message that together is easier. So I think if we can connect more, we can reach more people and more things together.
No, you're absolutely right. Thank you so much again for your time.
Thank you.
It was very nice to meet you, and have a great rest of your day.
Thank you. The same to you.
Thank you.